Selamat siang dan salam sejahtera untuk kita semua. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan rahayu, salam sehat. Hi, good afternoon everyone. In this lovely and beautiful day indeed, we hope we are always in a good health. And good afternoon, ladies and gentlemen. My name is Dini Octaviati. And it's a really wonderful and precious chance for me to be your master of ceremony and also the moderator on this productive Saturday, March 19, 2022, in our big event with the topic Lesson Learned of Telemedicine Implementation from Different Countries. We would like to inform you that today's special agenda, we will be participating in the International Digital Health Webinar, which held by UNDP Indonesia. In collaboration with Indonesia Telemedicine Alliance, or ATENSI, we also would like to inform you that this webinar is supported by an interpretation feature. So, ladies and gentlemen, you can click the globe icon on the bottom right of your Zoom screen and then select the preferred language in your convenience, either on Bahasa or in English. Okay, ladies and gentlemen, with the COVID-19 appearance around the world, the use of telehealth become more effective. Data in Asia shown that the telemedicine marketing Asia Pacific also growing from 8.51 billion US dollar in 2019 to 22.45 billion US dollar in 2024. The Indonesia Telemedicine, or known as Temenin, managed by the Ministry of Health since 2017, provides four main services: teleradiology, tele-USG, tele-AKG, and also teleconsultation that have been integrated at 237 hospitals and primary health facilities and connecting more than 800 doctor specialists in Indonesia. But even though it is a very good potential, Indonesian telemedicine has not been fully utilized by all levels of society, especially outside metropolitan cities, or we can say it's presumably centralized in urban area. The Indonesian Coordinating Ministry of Economic Affairs state that the percentage of telemedicine use is predicted to increase up to 109% in 5 years from now. But however, in the survey of SDG goals in 2021, it is found that 90% of countries and territory reported one or more disruption to essential health services by the impact of the pandemic. People who live in the poverty of rural area or elderly, indigenous population, minority, immigrant, and also person with disability are still facing obstacles to engage with the telemedicine in Indonesia. Regulation and policies in the telemedicine services industry in Indonesia are still need improvement. The possibility of unconfirmed diagnosis by the doctors, technological limitation, data security and patient privacy, and guidelines may make heavier the consequences associated with this type of treatment in health services. UNDP Indonesia and ATENSI work together to improve the sustainability of the telemedicine industry post-COVID-19 pandemic in Indonesia. And ladies and gentlemen, considering the urgency of policy and also the regulation to improve the access to health services in Indonesia, UNDP will continue to assist the Ministry of Health and the Indonesian Telemedicine Alliance, or ATENSI, to plan further action on digital transformation and telemedicine regulation in Indonesia. Ladies and gentlemen, allow me to greet the key person of this webinar. Hi, good afternoon and welcome to Mr. Irwan Herianto as a Deputy Head 1 of ATENSI. Hi, Mr. Irwan, and also we have Mr. Ciprianus Batesoro as a Head of DGPRU Unit UNDP Indonesia. Hello, Mr. Ciprianus. And then also we have here Mr. Setiaji as one of expert staff in health technology Indonesian Ministry of Health. And then we also have Mr. Daniel Oscar Baskoro as Chief Operational Officer GTO Indonesian Ministry of Health. Then we have also Mr. Faruk Quraish as a Technical Officer WHO Indonesia. And also we have Mr. Surahyo. Hello, Mr. Surahyo. Good afternoon, as a Project Associate of Digital Health UNDP Indonesia. Then from the panelists, we have Dr. Jeff Parker as Managing Director of GP Consulting Australia, And the second one, we have Dr. Adel El Taguri as the Director General of the Center for Accreditation of Health Establishment, the Ministry of Health, Libya. And the last one, we have Dr. Sazat Ali Khan as a Vice Chancellor Health Services Academy from Pakistan. Ladies and gentlemen, before we start today's discussion agenda, let's observe the opening remarks from Mr. Irwan Herianto as Deputy Head 1 of ATENSI. So to Mr. Irwan Herianto, the time is yours.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, Bapak-Bapak Ibu sekalian. Hari ini kita bertemu dan berkumpul ya untuk saling berbagi terkait dengan informasi-informasi, regulasi, dan lain sebagainya. Semoga acara pada hari ini kita bisa mengambil suatu manfaat ya. Ini merupakan kerjasama dengan UNDP, ATENSI, dan UNDP yang ke-5 ya. Terkait dengan apa yang akan kita bahas hari ini, pertama-tama adalah ucapan permohonan maaf kepada seluruh peserta. Kebetulan saya mewakili Prof. Purnawan Junadi selaku Ketua ATENSI. Beliau ada keperluan sehingga mewakili.
Hello, Mr. Irwan. I think there is the technical problem to Mr. Irwan.
Halo.
Okay, Mr. Irwan, please. Okay.
Ya.
Please continue. Okay.
Ya, baik. Tadi mungkin sudah saya sampaikan bahwa permohonan maaf kepada peserta bahwa sebetulnya harusnya yang menyampaikan adalah Ketua ATENSI Bapak Profesor Purnawan Junadi, namun karena ada keperluan beliau sehingga mewakilkan kepada saya untuk menyampaikan beberapa hal terkait dengan bahan yang akan kita diskusikan. Jadi telemedicine adalah merupakan suatu future reality. Jadi sepenuhnya ada di tangan kita. Kita mau menjadi pelopor atau kita mau jadi pengekor, ya. Itu menjadi amat penting, dan ketika berkait teknologi 5.0, batas-batas menjadi maya. Baik itu jarak ya, apalagi Indonesia terdiri dari 17.000 pulau yang punya masalah jarak, komunikasi, dan transportasi. Dalam segi pelayanan kesehatan ditambah dengan masalah infrastruktur, sarana, dan tenaga, telemedicine bisa menjadi suatu solusi untuk memperkecil gap tersebut. Tentu perlu kolaborasi dengan berbagai sektor karena meski telemedicine membebaskan jarak dan waktu, tetapi tetap memerlukan ketersediaan infrastruktur dasar minimal tertentu. Di pihak lain, telemedicine bukan panacea atau sebagai obat mujarab, tidak untuk semua pasien dan semua kasus. Tetapi saat ini seperti terbukti di banyak negara, di Indonesia ketika pada masa pandemi ini, telemedicine menjadi kontribusi tidak saja meningkatkan akses, tetapi juga mengurangi kesakitan dan mencegah kematian. Karenanya kita perlu konsensus di mana dan kapan telemedicine justru lebih tepat digunakan. Di masa depan, dengan makin majunya sosial ekonomi negara Indonesia, maka angka harapan hidup akan meningkat. Artinya apa? Bahwa lansia pun menjadi akan meningkat. Ya, usia harapan hidup meningkat, lansia meningkat, dan transisi ke penyakit kronik tidak menular, termasuk di dalamnya. Telemedicine bisa bermanfaat dalam sebagian kasus tersebut, khususnya untuk melayani lansia dan disabilitas. Tren di berbagai negara maju, caring berpindah ke non-hospital care, termasuk nursing care dan home care. Telemedicine bisa menjembatani berbagai moda pelayanan itu, sehingga lebih nyaman dan lebih terjangkau untuk masyarakat. Kami ingin mendengar juga dan belajar tentunya bagaimana telemedicine di negara-negara lain dan dapat berkembang dan mengatasi tantangan yang ada. Dengan benchmark telemedicine, ya, pada diskusi kali ini, dari berbagai negara, dapat menjadi pertukaran informasi terkait dengan regulasi dan bersama mendorong sesuatu opsi layanan bidang kesehatan yang bermanfaat bagi masyarakat. Tentunya karena kebetulan juga saya dokter, jadi beberapa hari lagi kami juga akan melaksanakan suatu muktamar. Muktamar ID adalah suatu agenda besar untuk dokter di seluruh Indonesia, memasukkan telemedicine menjadi salah satu agenda yang akan dibahas, menjadi suatu hal yang akan dibawa ke depannya, bahwa telemedicine ini menjadi suatu keniscayaan di mana dokter-dokter harus terlibat. Sebagai penutup, mungkin masih banyak tantangan untuk menjadikan telemedicine menjadi salah satu moda pelayanan kesehatan di seluruh dunia, khususnya di Indonesia, baik dari segi regulasi, pembagian peran, maupun kesiapan infrastruktur dan tenaga kesehatan sendiri. Saya berharap diskusi ini hari ini membahas berbagai tantangan tersebut. Selamat berdiskusi. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much, Mr. Irwan Herianto, for your remarks. The point is we still have to collaborate with one and another to build telemedicine ecosystem in Indonesia, actually. So, ladies and gentlemen, let's move to the second opening remarks, which will be given by Mr. Ciprianus Batesoro as a head of DGPRU unit UNDP Indonesia. So, Mr. Ciprianus, the screen is yours.
Thank you very much. I hope you can hear me well. Dear Honorable Deputy 1 of the head of ATENSI, Mr. Iriawan Herianto, Honorable expert staff for health technology of the Indonesian Ministry of Health, Bapak Setiaji, and the honorable speakers, all speakers for today's event, the Chief Operational Officer of the Digital Transformation Office of the Ministry of Health, my very good friend, Bapak Daniel Oscar Baskoro, the Technical Officer of the WHO Indonesia, Bapak Faruk Qureshi, the Project Associate for Digital Health, UNDP Indonesia, Bapak Surahyo, Honorable Vice Chancellor of Health Services Academy from Pakistan, Mr. Shahzad Ali Khan, the Director General of the Center for Accreditation of Health Establishment from the Libyan Ministry of Health, Mr. Adel El Taguri, the Managing Director of JP Consulting from Australia, Mr. Jeff Parker. Dear participants, ladies and gentlemen, good afternoon, good morning, good evening, depending on where you are right now. Thank you for joining us in this digital health webinar series, the fifth, with the special topic of the lessons learned from telemedicine implementation from different countries. We all know that the emerging cases of COVID-19 from all over the world have challenged us to accelerate in many aspects of life, including digital transformation. In health aspects, the digital-based health services known as telehealth or telemedicine have been utilized for medical purposes for decades. Today, the use of telemedicine to fulfill the demand of health services among the population has significantly risen in recent years. For example, the projection of telemedicine market in Asia Pacific will keep growing from over $8.1 billion in 2019 to almost threefold to $22.5 billion in 2024, as it was already alluded by our dear moderator. The number of visits to one of telemedicine service provider in Indonesia reached up to 32 million visits during Q1 alone in 2021. And most of the providers experience 2 to 3 times higher the number of patients per day during these years. Eventually, the COVID-19 pandemic has brought telemedicine to grow and invest in a new, inclusive, whole of society healthcare system in Indonesia. One of the UNDP efforts to achieve the SDG goals and leave no one behind as simultaneously respond to the crisis caused by the pandemic is the contribution to restore the economic and social aspects globally. In the health aspects, UNDP has also contributed to the development of the technology-based health services, bridging the gaps of access to healthcare among population living in diverse geographical and demographic situations. Since 2018, UNDP Indonesia has actively supported the digital transformation in health services, starting off with a vaccine monitoring system through the SMILE application project, which has supported more than 10,000 primary health care providers across Indonesia to deliver and monitor the supplies and quality of vaccines for COVID-19 or the vaccines or other vaccines to the population. UNDP also has supported and accommodated the technical assistance towards the digital health transformation in collaboration with the Indonesian Ministry of Health, which successfully launched the blueprint of the digital health transformation 2024 in December 2021. Generally, UNDP have encouraged the allocation of resources to discuss, develop, and advocate to relevant stakeholders to accelerate and ensure the sustainability of health digitalization strategy. Ladies and gentlemen, despite the support and achievement in transforming the digitalization in health, Indonesia remains facing the JC challenges, that is the gender equality and social inclusion challenges, including reaching the population living in poverty in rural areas, the elderly, the indigenous population, migrants and minorities, and people with disabilities who are still facing barrier to engage with telemedicine services, as it was reported in the JC in Telehealth report in 2019. The high disparity in the amount of medical equipment, as well as competence of health professionals, added by the inequality of digital access, further marginalizes more than 70,000 villages who live below poverty line in Indonesia. As one of the series of strengthening telemedicine services in Indonesia, UNDP, in collaboration with the Indonesia Telemedicine Alliance, or ATENSI, has conducted this series of webinars to facilitate healthcare providers, private sector, academician, stakeholders, and general public to discuss and share insights in regulating policies and other regulations to improve telemedicine sustainability post-COVID-19 in Indonesia, including telehealth regulation in improving the access, ethics and legal aspects, financing policy, as well as the most important in telemedicine in future contribution to marginal and vulnerable group. This is very important to ensure that no one is left behind in the advancement of telemedicine in improving population health. So, ladies and gentlemen, today, by the presence of our international partners to share their perspectives and experience from providing telemedicine in their countries, I hope that this webinar could be an effective knowledge-sharing platform among countries to improve telemedicine services to be even more resilient and sustainable in the future. I thank you all for your attention, and I'm delighted to witness the constructive discussion today. Again, thank you very much for your participation, attention, and your contribution to the session today, and may it all bring even more benefits to all of us and to the society in global terms. Now, back to you, the moderator. Thank you very much.
Mr. Sipli, Ciprianus, thank you very much from UNDP Indonesia. So no one left behind in telemedicine improvement in Indonesia. Once again, I thank you, Mr. Ciprianus, for the remarks. And ladies and gentlemen, we have our next and last opening remarks will be given by Mr. Setiaji as expert staff in health technology from Ministry of Health of Republic of Indonesia. So I will now hand over to the screen to the Mr. Setiaji. Mr. Setiaji, the screen is yours.
Yeah, thank you. Sorry, the unmute cannot. Okay, thank you, Mbak Dini. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen, the Honorable Mr. Ciprianus from the UNDP, and also Mr. Iwan from the ATENSI, and honorables, all of the speakers today, and all of the participants. First of all, I would like to thank for the UNDP and ATENSI for all of support to the Ministry of Health, especially for the DGO, to accelerate our programs to digitalize the healthcare in Indonesia. Indonesia actually has more than 270 million people spread across an archipelago of over 17,000 islands that faces a range of challenges in healthcare delivery and access. Moreover, Indonesia has 2,500 hospitals with 1.2 beds per 1,000 populations and 0.38 doctors per 1,000 populations. Compared to the WHO recommendations, the condition of the healthcare system in Indonesia is one of the lowest in Southeast Asia. Going from these challenges, we see an opportunity, especially the use of information technology. Indonesia has a huge potential with 202.6 million internet users and still growing. More than 16% increasing smartphone users has $44 billion growing internet economy in ASEAN as the largest and fastest, and expected 60% digital healthcare revenue growth in 2022. Digital transformation accelerated during COVID-19 already did in Indonesia. We learned from the COVID-19 pandemic with less and less mobility. The development of technology and automation will be accelerated to be able to continue to connect every human activity. Likewise, in the healthcare sector, we've started the digital health transformation in order to handle the spread of COVID-19. Yeah, we know the future of healthcare is sure to bring even greater advancements that further simplify healthcare for both patients, medical professions, and also governments. The telemedicine will help physicians, primary care, and hospital staff perform their duties comfortably and intelligently. First, it can help in the creation of more customized and patient-oriented equipment. Moreover, it will also enable patients to get better access to data, personalized care, thus leading to fewer visits to the hospital. Telemedicine in the future plays a significant role to address specific problems with traditional healthcare models and has the potential to improve access, quality, and cost of healthcare, and the patient as a consumer experience as well. The Ministry of Health acts as a catalyst and also a regulator, not a player. We will make sure how we support innovation and virtual services to run and have a big impact but still comply with health and legal ethics. Actually, in this year, we already start to run what we call the sandbox regulatory for the telemedicine and also some virtual health to support the malaria. And we will more expand, not only for some disease, but all of disease using like telemedicine and also the virtual. One of the things we are doing is during the COVID-19, the Ministry of Health issued a policy related to guideline for health service through telemedicine during the COVID-19 pandemic period. Due to the increased potential risk of transmission between doctors and patients in the COVID-19 pandemics, telemedicine is allowed between healthcare facilities and patients to reduce risk, and also we collaborate with telemedicine companies to be able to provide health consulting services. We hope the collaboration between the Ministry of Health and also the ATENSI and UNDP, especially to implement the telemedicine system in Indonesia, will continue in the futures. And we hope the support can be growth of the ecosystem so they can give more impact to society. We really appreciate this webinar. We hope this event can give us more insight about the implementation of telemedicine in Indonesia. Thank you.
Thank you very much, Mr. Setiaji, as expert staff in health technology from Ministry of Health of Republic of Indonesia for your opening remarks. So, based on your opening remarks, telemedicine in Indonesia has a great potential based on internet user in Indonesia. And I think all Indonesian people having a great or a same opportunity to have a better future in telemedicine. Okay, ladies and gentlemen, after the opening remarks, before we continue to the next agenda, we would like to memorize this moment. So we kindly invite you to do a photo session together. Please open the camera and give your best smile for all of us. Okay. Okay, you can open your camera and give your best smile. So I will start the countdown. 1, 2, 3, smile. Okay, one more time. Give us your countdown. 1, 2, 3. Okay, thank you very much, ladies and gentlemen, for your best smile. Okay, dear participant, right now we will move on to the next agenda, which is presentation and discussion session, where we will discuss the main topics and resource person will also share their experiences. We want to inform you, if you have any question during this session, please type your question and send it through the chat box. And once more, we would like to remind you that this webinar is supported by an interpretation feature, so you can click the globe icon on the bottom right of your Zoom screen and select the preferred language in English or in Bahasa as your convenience. Ladies and gentlemen, with the topic of telemedicine implementation in Indonesia, challenge and opportunities, please welcome Mr. Daniel Oscar Baskoro as Chief Operational Officer DTO, Ministry of Health of Republic of Indonesia. Mr. Daniel Baskoro, the screen is yours.
Okay, thank you so much for the moderator already introducing my name.
Hello, Mr. Daniel.
Thank you, Bu Dini. Yeah, hello everyone. Yeah, my name is Oscar Baskoro as a Chief Operating Officer at the Digital Transformation Office, Ministry of Health. Thank you so much, UNDP, for inviting me as part of the panelists on this today discussion. So, also one regards for the speaker and also for the representative that also joined on this event, from representative from the ATENSI and also my good friend Sipri from UNDP, and also Pak Setiaji, and also the others are the speakers that also joining on the today discussion from the WSO, Mr. Farouk, and also Mr. Surahyo, also from the UNDP, and also some panelist discussion from Jeff Parker, Adele, and also Sunset joining on the discussion. So for the today discussion, I will present about some experience, some challenge, and also some opportunity related to the telemedicine for the insight and also for the information that can be helpful for other countries and also for our Indonesian partner to enhance the quality of the telemedicine. So I will show my screen. Yeah, can I show my from my laptop?
Okay, but probably your sound is like a little than the presenter before. Then, okay, I cannot hear your sound actually, Mr. Daniel Baskoro. Hello, hello, Mr. Daniel. Hello, Mr. Daniel. Is there any technical problems? Okay, ladies and gentlemen, I think we should have to wait. It is probably Mr. Daniel having technical problems. Hello, Mr. Daniel. Can you hear me? Okay, ladies and okay. Hello.
Can you hear me? Yeah,
Hello?
can you hear me?
Yes. I can hear you very clearly. Okay, this is better.
Oh yeah, okay, sorry. I think I just experienced some
Okay,
problems
it's
with my
okay. No
laptop.
worries, Mr. Daniel. The time is yours.
Oh,
Okay, please continue.
okay. Yeah, I will continue my presentation. So I will share my screen. So I will present about the experience of the implementation of the telemedicine. Could you see my screen?
Yes.
Okay.
Good.
Yeah, I will share some experience during the pandemic and beyond. Then this is can be the helpful information for the all countries, also Indonesian partner that want to enhance the capacity and also the quality of the telemedicine in Indonesia. And this is a quick brief information that I want to inform. So in the Ministry of Health, usually we're thinking about the digitalization is only during the crisis situation. But in this digital transformation, we want to enhance, we want to extend the digital transformation not only during the crisis, but also begin from the beginning of life. So this is why we want to put the digital transformation is not only about the curative, but also about the preventive and also promotive for the healthcare services. And that's why we put the digital transformation from the beginning of life, from the baby, and then from the children and the teen, and then also adult and young adult, and then adult, and also in the critical situation. So we want to put digital transformation into all aspect end to end. So this is why the public services is in the health sector very important, especially the implementation of the digital technology to put all of the data integrated and also to put all of the healthcare services is using the technology, so having the good quality and also good use from the many health workers. And to implement about the digital transformation end to end, we have some challenge, but also we have some opportunity. So that challenge that we have, actually, we have currently a lot digital transformation initiative in the health sector. That's the challenge. Why is that's the challenge? Because all of the digital transformation is still in the silo. So we have a lot apps, a lot digital software in the health sector, and that's make the health services more complicated. In other side, there's still a lot. Many documents is still not digital. We have many medical record still writing the paper, and then many management of the hospital or the health facility still manual. So we have a lot of app. It's a challenge, but if we don't have, that's also the challenge, because we cannot have the more effective healthcare services because of the process, the manual, and also still still on the paper format. And also the challenge is about the capacity of the health services in Indonesia. We have very limited doctor in Indonesia. Only 0.38 doctor per 1,000 population. That's a huge challenge in Indonesia. We have big population in Indonesia, but the doctor is limited. So in other side, there's also the challenge in the hospital situation about the bed ratio ratio in Indonesia. The ratio is only 1.2 hospital beds per 1,000 population. This is a huge challenge in Indonesia. The apps, the digital technology, still there and still in the silo. Still, many health facilities are not having the technology, the capacity, and also the ratio of doctor still limited. Hospitals still limited. That's the challenge that currently we are facing on. But in the other side, we are seeing about the opportunity about the user of the digital technology in Indonesia. We see about the increasing growth of the user using the smartphone in Indonesia. Currently, we have the 200 million people using the internet. That's a big number in Indonesia, actually. I just had discussion in the global forum, and at the country also realized that Indonesia is having the good opportunity of the digital transformation health, because we are having the good number of the internet user. In other side also, the internet user also using the smartphone as a tool for accessing the internet. And the investment is also big about the healthcare, digital healthcare, especially in the ASEAN economy. So we have a lot of challenge, but also we have the opportunity in the technology. So we want to combine that as a solution to solve the many challenges about on the healthcare services in Indonesia. And the important aspect also about the pandemic situation. So the pandemic situation is accelerating many digital health transformation in Indonesia. So as we know, before the pandemic, we are never thinking about the digital transformation in health. We are always thinking like, why are we so thinking about health? Why are we so thinking about the digital transformation health? Because we don't have any virus, and then the virus can be like the virus like very normal. We can get healthier condition only by using the medicine. So we are not have any concern on the digital health. But during the pandemic, health is very important, and people are always discussing. We're talking about the health, improving the health quality, also providing the good health quality services, and also quick response during the pandemic. Then that's why the digital transformation also accelerated because of this pandemic, and this is the opportunity that also we have. We have the opportunity about the internet number users in Indonesia, but also we also have the push from the public, from the government, to accelerating the health services by using the digital technology because of this pandemic. And also Indonesia in this G20 presidency also putting this health aspect as a one focus and as a one priority. We have the focus about the building the global health architecture. This is important because currently, in the pandemic situation, we just realized we don't have any good health architecture. There is some chaos in many aspects in the health devices, health medicine, about the interoperability of the data, about the capacity of the financial for health. So many aspects that still a challenge during the pandemic. And that's why Indonesia also having the focus on the global health architecture. That also very important here to be recognized, to be understood by the all leaders in the world that the digital health, the health aspect is important. And based on that condition and situation, so just last year, the minister launched a new office, new team, special team for the digital transformation in Indonesia. This is actually a very unique initiative maybe compared with the country that usually digital transformation is very general, but currently in Indonesia we have more very specific digital transformation office in the health. So our digital transformation office in health is already here in Indonesia, and we have some focus and some priority in our mission. And basically, the mission is about accelerating the digital transformation in the health aspect. If we are usually thinking like, okay, let's put the digital transformation for health in the next 5 years or next 10 years, and then from this digital transformation office, we put the target more short. Let's put the digital transformation in the next 2 years, because people can wait. People don't want having the chaos during the next pandemic, during the next situation, or during the next crisis. So this digital transformation is the main goal is about accelerating the digital transformation in health, so we can have more good health quality in the short period. And in this digital transformation office, we also have the program about the expanding the telemedicine services. As I mentioned before, we have the challenge about the limited capacity of the doctor, also the especially also about the doctor specialists. So by using telemedicine, we will want to transform. So we're not sending the doctor to the location, but the doctor still in the doctor location, but he or she can serve. He or she can give the service for the health services for many citizens in Indonesia by using the telemedicine. So this is actually the goal of the telemedicine, especially Indonesia as an archipelago country in the world. We have 7,000 and also have 270 million. To solve the issue about to make the health coverage for all Indonesian citizens, is the key is only the technology. So we want to put the telemedicine to solve the issue, to put all health services in Indonesia. And this is why we also launched some policy on that. We have the policy on the telemedicine. Yeah, there are the two policy currently already developed by the Ministry of Health. The first policy is about the telemedicine from the health facility to the health facility. So this is very basic telemedicine, yeah, from the health facility to health facility. But the second one, we have the policy about the health facility to the public, and also specifically for the COVID-19. That's the important thing. So the telemedicine is the technology, but we need also develop the policy as the baseline to put the services in the same standard and also the same quality for the all citizens. And this is the second policy and as a second program, yeah, that we built about the telemedicine for the public. So the telemedicine for the public actually very emergency program that we built last year. We built the regulation. It's only just in the 1 week. So during the Delta situation, yeah, we realized that the capacity of the bed ratio in Indonesia is very low. If we are already thinking to use the hospital as a main service for the COVID-19 situation, and this can be the solution, because we have very limited health facility and also we have very limited doctor. So the minister asked us, the Digital Transformation Office, and many other team, yeah, in the Ministry of Health, to thinking about to solve the issue. And then we have the solution. The solution is about putting the telemedicine as a key to solve the limitation of the health services during the pandemic, so especially during the Delta situation, that our number of the cases is very high, and then we have the very limited situation. And we are building this program, the telemedicine for the self-isolation patient. So in this program, it's really very interesting that we're combining many initiatives into one ecosystem of the telemedicine. So we're having like most currently like 6,000 packets of the medicine delivered to self-isolation telemedicine self-isolation patient every day, and also more than 7,000 patients access the consultation on telemedicine every day. So this is actually solving the issue of the limitation of the bed capacity in the hospital. You can see 6,000 not coming to hospital, and then they already receive the medicine, and 7,000 patient get the services for the COVID-19, and then this also reduce the limitation of the health facility and the bed in the hospital. And this is the telemedicine for the COVID-19 that we built. So we built end-to-end services. So each of the patient that getting a positive result in the lab, they get notification from us to go to receive and also to use the telemedicine for free. And then after they use the telemedicine, and then they receive the medicine directly in the hub. And we built the telemedicine not by ourselves, but we collaborate with the 17 telemedicine star. So this is the important things about building the ecosystem of telemedicine. So telemedicine is not only about the government program. The telemedicine is not only about the government role, but telemedicine is about the collaboration with the stakeholders, with the ecosystem of the industry. So this is the key why the program is success. We collaborate with many startups, so the many startups can collaborate, help us to solve the issue about the consultation. So they give the consultation for the 7,000 patients every day, and also the startup also from the career delivery, they're giving the packets of the medicine every day to the patient. And this is actually the process that I already told before. So when the citizen get the positive result from the PCR antigen, and then they receive the notification, and then they can and also they can go to the telemedicine platform to have the consultation, and then they receive the prescription, and then they claim the prescription, and then they receive the medicine. So the step is very easy, and you can receive the medicine in only usually the average is only 24 hours. It's maximum in some case in 48 hours, but in the average it's 24 hours they receive the medicine. So this is the process, and then this very easy, and also solving many the issue about the limited health facility and also the doctor in Indonesia. So you can see here we integrate many different platforms, many different apps into one ecosystem. This is from the testing lab, is the one apps, and also this is from the WhatsApp, is the one apps. This is the startup apps, and also the startup apps for the prescription, and also this is for the medicine delivery. So we're combining many different technology into one ecosystem as a solution during this pandemic for the telemedicine. And we also integrate the telemedicine services into our app, Peduli Lindungi. We have the integrated app for the health services during pandemic. So we have the Peduli Lindungi app for the screening, and also for the testing, and also for the traveling, and also for the vaccine registration or vaccine proof. And we integrate these services in the Peduli Lindungi. So this is also important.
Pardon me to interrupt you. So you have 5 minutes left. Your time to present. Okay, thank you very much.
Yeah, and this is the important thing. So we want to put the information of the telemedicine is open to the public, and also easy for the public. So this is the ecosystem that we built. So we integrate the services into the one app, but the consultation can be done with the other startup. So we integrate the telemedicine also in this ecosystem of Peduli Lindungi. And for the long term, we also have some transformation priority in the digital healthcare. The first aspect is about the data management and the health aspect, and the second thing is about the integration of the app to make the app on the health facility more efficient. And the last one is about the ecosystem. This is the important thing. In the long-term goal about the telemedicine, we want to put this as a digital health ecosystem. So we want to expand the telemedicine technology, not only for COVID, but for many other diseases and many other health services in Indonesia. And also we want to improve the number of the startup, number of the product related to telemedicine. This is the key. We don't want a supplier in the telemedicine. We want to put Ministry of Health as a regulator, as a policymaker, and also as a catalyst to enhance the ecosystem of the telemedicine. So we built the regulatory sandbox, we built the many policy to improve the capacity, the standard, and also the number of the telemedicine platform. So the ecosystem, the last priority is about building the more good quality of the health technology in the industry. And this year, our goal is about developing the policy, developing the regulation related to digital ecosystem, also developing the ecosystem, the many program related to the digital health. And we will launch some of the initiative this year, but most of the implementation will be done in the next year and the next following year, 2004. And in other side, we also put the telemedicine, is in the one integrated ecosystem of the digital health in Indonesia. We call it with the Indonesia Health Service Platform. So platform as a service. So this is the goal. As a regulator, as a policy maker, we want to put the Ministry of Health as a platform to integrate many services on the digital health, including the telemedicine. So we want to connect telemedicine with the other services, for the referral services, for the primary care services, and also maybe from the medicine logistic, and also from the number of the health workers management into one platform. And then we are building this Indonesia Health Service Platform as an integrated platform to many health services in Indonesia medicine. And this is the principle of the Indonesia Health Service Platform. But actually, the main goal of these principles is about connecting all of the industry of the digital health. So we want to have more digital health technology projects here in Indonesia. And all of the technologies should connect to our platform, to the Indonesia Health Service. So we don't want to build the telemedicine services, but we want to build the platform to connect all of the services from the startup related to digital, related to telemedicine. And this is the standard of the data. And also the important thing is about the standardize the data and services. We have the standard data and the services that can be the reference, and they can, and the startup and the industry of telemedicine can connect on this platform. And this is also the future of the Peduli Lindungi. If we currently have the Peduli Lindungi as for the COVID-19, in the future, we will improve the services for the many health services, not only for the pandemic services, including for the mother and children services and also other services. So you can get health services into one single platform in the Citizen Health app. So Peduli Lindungi will be the super app for health services in Indonesia. And this is the example of use case that the integrated services on the health facility and also the referral services and telemedicine into one platform in the Indonesia Health Services. And this is the important thing, that all of the data is not only used for the integrated services, but also used for the decision making. So we use the data as our baseline for decision making. So we can have more accurate policy making, including in the local level. So we can have also the precision medicine. We can also have any other services and also other function, because using the baseline of the accurate data based on the services on the telemedicine. And this is the example of the health tech space that we want to build. So that we are supporting, yeah, for the industry ecosystem as a startup ecosystem for the telemedicine is not only about the policy, but we are also building the physical space. They can work in the one space, in the one location, to have the incubation process, and also we have some program for training, for community development, and also many a program for matchmaking. So this is how we build the ecosystem, not only about the policy, but also building the physical support, and also about building the matchmaking into the government and all other services. And this is the key also, but also the regulation is still there. The important thing also, we want to build the regulation, yeah, about the telemedicine, not only for the COVID, but also for the telemedicine for public. So we launched the policy, the regulation for the telemedicine for public this year. We're expecting to launch the regulation about telemedicine for public this year. So the regulation will cover about the standard of the service, about the flow of the service of the telemedicine for the public. So before that, we only have for health facility to health facility, and we will, in this year, we will develop for the health facility, for the industry, to the public more easy. So they can have the baseline, they can have the foundation, yeah, to have the product or to have the service on telemedicine, because we have the regulation for the medicine for public. And we are also putting the regulation sandbox as an important thing. So other telemedicine that want to build and then still on the development process or still on the prototyping process and the development stage, they can still involve in this ecosystem by joining the regulatory sandbox of the digital healthcare that we will launch in this year also. So we will put this like in the finance sector. Yeah? So many other apps on the digital health can join on the regulatory sandbox, then they can test and can have the express of implementation in the public. This is the flow of the regulatory sandbox. And anyway, this is the last slide. So we are as the government, Ministry of Health, very open for any collaboration with the digital health partners from the health sector to join in our digital health innovation ecosystem, from the university, from community, and also from the insurance industry maybe. So we are open for any collaboration. We can collaborate as an expertise, for example, to involve about the development of the policy, or collaborate as an implementation partner. For example, during this pandemic, we collaborate with many startups, to implement the telemedicine services, That's also the potential collaboration. And last one about the fellowship collaboration to support us in our team to develop, for example, for this develop Indonesian health service platform. If there is any startup that want to support the development of with the fellowship with the team on the Indonesian service, we are open. So we are open for any collaboration with all of the partners ecosystem. So just ping us on the email tpo@kmcast.id for any question or any potential collaboration, and we are happy to answer, because we want to make faster the process of the digital transformation for health in Indonesia. I think that's all the presentation for me, and we can have the discussion later in the Q&A session. Thank you so much.
Thank you very much, Mr. Daniel Oscar Baskoro. Very, very insightful presentation. So we still have a lot of homeworks to do to build the great ecosystem or potential ecosystem related to the telemedicine ecosystem in Indonesia. But I concern about your statement in your presentation, government as a catalyst for digital health ecosystem. So hopefully the next future, we can be a great potential ecosystem in Indonesia to build the strong telemedicine ecosystem in Indonesia. Okay, ladies and gentlemen, moving on to our next speaker. Let's pay attention to the next topic, the expansion of telemedicine to reduce health disparities by Mr. Farouk Qureshi. So Mr. Farouk as a technical officer from World Health Organization Indonesia. So I will now hand over the screen to the Mr. Farouk Qureshi. So Mr. Farouk, the time is yours.
Yes, good afternoon and selamat siang, everyone. Thank you very much, Vania. And really thankful to all the speakers, Pa Ciprianus, Pa Setiaji, Daniel, Pa Irwan, for some insightful introduction to the digital health systems in Indonesia. My name is Farouk. I work here in WHO Indonesia. And that's very important because what I would like to present is not the digital transformation, but what I would like to present and look into is the more deeper insights into how this digital transformation should be looked into a pure public health perspective and how the benefits can be reaped. And I will just maybe at the start, I would like to give an analogy. When Daniel started his presentation, suddenly the technology didn't work. And that's where the analogy is, that what we aim to look at in terms of health quality and health services is that the right technology is available at the right time for the right people in the right way. And it does work. So that's where we all aim together to move ahead. And well, it might be a blooper, but also it was a good to give an analogy on how we need to look at the public health side when we are looking at the use of technology. If I may ask, Vanya, would you present or should I share my slide screens? Okay, I can see my slides. Is it coming already or should it?
Yes, it's already. I can see very clearly your presentation. So let's continue your presentation. You have 20 minutes around, Mr. Farouk, by the way.
Okay, thank you. I'm sorry. Right. So, and the topic was given to me was telemedicine to health inequities, address health inequities. So that's very interesting because what we have been talking about is an expansion of telemedicine in terms of the digital health. And that's where overall, I think the overall global discussion and communication is going on. And that's very right. But also important aspect is when we look at the health, there is this subset that is very important because that is the subset that we need to target in practical sense. And that's where most of the countries want to include those who haven't been reached through the conventional mechanism or those who are left behind. And that is where the potential role of overall digital health paradigm, but also specifically telemedicine needs to be looked at. That's why I just thought that maybe I'll spend some time one-on-one on each of these aspects, health inequities, and then getting into the gist of how really telemedicine is important, and then looking more into what does it actually mean. Is it okay? I'm sorry, sometimes because I'm using multiple screens. So what can you see? Can you see my slides? I can't hear you.
Hello? Mr.
Hello?
Yes.
Can you see my slides?
Yes, not yet.
Again, a blooper.
I cannot see your slides right now.
I sent it coming.
Okay, probably.
Maybe can you start from your end?
Okay. Or maybe you want to share your presentation by your own self?
No, it's fine.
Fine, okay.
Yeah.
Mr. Farouk, sorry, we still have to wait.
Yep. Again, that's where
okay.
I think
it's getting solved right now. We can see your slide here.
Okay, so if you are going, is it the slide 2?
Okay, we are going to move to the slide 2. Second slide, okay.
Yeah, the colorful slide.
The right slide.
Right.
How do we address health inequities in a health system?
Okay, so I'm sorry, colleagues. I think I wanted to bring your attention first on the word health inequities, because somehow when we talk about digital technology, we do miss out where our intent is. And I mean, even in a health systems perspective, when we are looking at the health inequities, we have mechanisms to identify how and health inequities persist in a system, in a social system, in a country, in the populations that we are intending to target. And that's very important, because that is where the need to design an appropriate intervention that would use digital health platforms. Now, that's one aspect of it, but also important aspect of it is that unfortunately, health inequities within a health system are at multiple levels. It can be at the level where the state is responsible to provide financial protection or universal health coverage. But then it can be at a level where, you know, there are quintiles or populations that are receiving very well established primary health care, but then there are populations that are not receiving very well primary health care because of the hard to reach areas, because of their inability to access those services due to their inherent personal and family conditions. So these aspects really need a thorough analysis and in-depth review to target what are we intending to achieve as a potential outcome or benefit of the use of the telemedicine. So that's one important aspect. If you go to the next slide, please. And that's why the principles of assessing health inequity hold an upper ground before we really talk about the potential benefit and use of these, especially these technologies, especially the telemedicine. And I'll come to that, because somehow the telemedicine itself is blurred into more broader areas of digital health, mHealth, and etc. Now, as I mentioned, that there are mechanisms in place, and this is where the role of WHO and such intergovernmental organizations and technical academia is, to find where the problem is, what sort of population is the one that need to be, you know, benefited from a certain solution, and then what is the solution that is going to, and what is the solution is going to do actually. So what would be the end result of that solution? And that is where, you know, a broader aspect of health inequities would be addressed. Unless we do not identify focus, it might be impossible to identify what is the best approach, even within the telemedicine. So that's an important consideration. Now coming to the telemedicine aspect, next slide. We did hear from Pas Tyagi, and especially from the DTO colleague on the design and architecture of digital transformation. And if you ask me as a layman, absolutely that is necessary, but also that meant that most of the initial planning and initial implementation would be to address the technology side rather than the public health side. And that is very fair, because that is the need. Unless you develop those platforms, you cannot use them appropriately. There's no question in that. But then looking deep into it, when we look at the digital health and the way it encompasses the public health or its use in health, it's not limited to one particular area. We do have e-health, mobile health, electronic management system because of the data management. Telemedicine is just one part of it. And that is why it had to be defined very clearly. What do we mean by each of these elements and areas? And for telemedicine, the focus is provider to provider or provider to client relationship. And that is where usually our definition of telemedicine really focuses on. but it does go beyond that because because of the interoperability, because of the changing advancement of the technology, and even the use of the technology. Now, nobody is only having a consultation with a patient through an earpiece. They are having more consultations through these apps, maybe. So yes, the interface is a bit overlapping, but at the same time, it's important to know that. Next slide, please. And all the more important aspect also is either the use, when we are looking at the use of telemedicine or broader digital health, what is the intent? Overall, what we can see in terms of health are these four pillars: improving access, expanding the coverage of the health services and healthcare, increasing financial efficiency of the system, and supporting equity. Something that I was asked to maybe concentrate a bit more. But just to give you an insight from a public health perspective, we may look at the type of the systems, we may look at the interoperability models. There are potential dimensions of digital health and digital technology. There are aspects that might have commercial elements, public use elements, the state responsibility in terms of policies and processes. But then where is the beneficiary? That is very much important. And what is the intent of the benefits is most important aspect when we look at the use of telemedicine. Next slide. And that's very interesting now. I'm trying to give you a snapshot of some insights, because I think that is very much important for even for non-public health professionals or those who are in the digital health domain to understand that from the user end, from the public health end, it would be important to define clearly where the potential benefit, cost-effective benefit of digital health and the telemedicine would lie. Now, the cascading model in this picture illustrates how health systems lose performance because of challenges at successive levels. And there are various levels, as you can see: supply, demand, the quality assurance, and then even in terms of applicability. I've highlighted or encircled these three areas where we think the most appropriate focus of telemedicine can be. And remember, now I'm getting into more deeper side of the telemedicine, not overall digital health or not overall digital health platforms. And that's important consideration, because I think even in terms of the technological side, while there might be overlap, what we are looking at is reaching those people where the solutions can be by the use of a simplest technology. Even if it is part of a bigger digital health paradigm, that is fair, that is fine. Maybe mobile phone penetration is good, but at the same time, the interface should not be complex enough that those who should be reached out feel to be left behind. So that's why important aspect of telemedicine is that the value of telemedicine in terms of its scope and the value of telemedicine in terms of their beneficiary and the type of the interventions it would deliver should be very clearly defined. And that's why I would like I wanted to point out these. Now, making it sense together. Next slide, please. I think the key point here is that overall the digital interventions should be identified according to the inequity challenge that needs to be addressed. And that same goes for telemedicines. By definition, we are talking about consultations between a client and a healthcare provider, or remote monitoring of client health or diagnostic data, or transmission of medical data, or consultations for case management that is usually provider to provider. That is fine in terms of the operational scope, but the important thing is the outcome scope. And that's where the challenge needs to be very clearly identified and appropriate interventions to be taken up. Why? That's very, again, I'll allow me to now come to some blast from the past. What do global reviews inform us? Since 2005 or even earlier, WHO has been working on the potential value of telemedicine, how it should be used, where it should be used. As WHO and public health entities were looking at it, probably the digital technology moved at a much faster pace. The adoption of technology, the change of technology, updating of technology, and even the use of technology has definitely improved a lot more than that. But then we tried to find out, okay, well, where is the evidence that whatever had been initiated, maybe piecemeal, is it really working? Is it really working rightly? Is it really working to the level where we would like it to work? Has it really good outcomes? So there was this 2012 review of 7 long-running telemedicine networks between 5 and 15 years of their timeline, usually from those countries, Africa and Pacific Islands, so not from the developed countries. I thought that I think this is one of the good case examples to look at some of the benefits and even challenges of the telemedicine. Now here you see that while there was an expert base, experts are those who are providers and maybe users are those who were recipients. They did increase, usually, not necessarily in every of these 7 identified, networks, but still, the key finding was that they were using a store and forward system. So it was not an instant service. So they would probably do it within the next 12 to 24 hours, and usually that was the lag time of service request and service provision. But then the experts were mostly loosely attached, mostly volunteers. Only a few networks were looking at their accreditation status. So now here you can start trying to identify why I am bringing a depth of public health perspective here. The use of technology and very rightly pointed out by my colleague that it is a catalyst, but the catalyst has to be used appropriately, and those who will be using those catalysts need to develop those standards and quality that needs to go through that catalyst. Now, coming to the next slide. The performance measures that were looked at were really not giving, okay, the question was whether the outcomes that were intended from these networks are being reached at an appropriate level. And if you see, there were some good things, that there was a dialogue between the provider and the requester, but did the experts receive any feedback on the outcomes? I have given a medicine to a patient through my e-health. What happened to the patient? Do I know? How do I know it? Little qualitative or verbatim, I put in brackets because probably these words were never used there, but think of how do I judge whatever service was provided was of good quality, what was mentioned in counseling, and then what type of the results they were there, what type of the papers came out from these 7 networks. And you look at that, these were usually case reports or just a limited number of interactions that were reported in form of the knowledge. So these all give an insight into the potential challenges. And let me get back to this slide 10 now, highlighting ongoing challenges. So what we are looking at is the standards of telemedicine services and counseling and quality of patient outcomes. We aren't there yet. And I agree that we are evolving. These are the need of the hour, especially COVID has created that ripple effect that the countries, and especially developed countries, many developed countries have started looking at it. But because as public health professional, as a clinical professional, that is where I would like that a patient that is being served through a telemedicine system should get the same standard of advice and care that anyone across Indonesia, any service provider through telemedicine would be for that particular patient. So think of those standards that have to be uniform. Then issues of liability and confidentiality. What should we do about that? How the medical records are taken up and kept? And think of these inherent sustainability of these networks, anchors who are the ones who bridge this communication, either by records or by virtue of they being just operators. Institutional models, whether these networks are run by a single person, a few persons, or a very organized institution system is in place, and then the service is presented. Now, we can provide a service in terms of providing a prescription for medicines. That might be one end, but then let us come to the fact that not all patients might be requiring only that particular solution. There should be referral pathways, and there should be critical care pathways that need to be ensured that while we can find a basic synopsis of symptoms, the next stage that should be inherent to any digital technology or digital platform is to get the potential of in-person help. And then looking at the quality technology updates, as I mentioned, because every other day your iPhone or your Samsung starts asking you to update its software. So are we really geared towards having those systems in place that qualify the pace that is required in terms of advancements by the technology? And the biggest public health side is the strength of evidence of services. As yet, even to date, it's not only this 2012, the strength of evidence of services, still we haven't reached that point where we have enough valid, systematically organized case control trials or reviews. And I'm sure many speakers who would come down after this presentation would probably provide some further insights on it. So stronger evidence is needed to document appropriate use of, and what about outcomes? Where does the patient go? What happens to the patient? If I need to scale up across Indonesia, I need to know whether whatever I am proposing to one patient or 10 patients would be applicable to 100 patients and with an outcome that is expected. So please be aware that at one end, the potential of digital technology and telemedicine is there. The reality check would be very important when we look at what and how this telemedicine should be used. And that brings me to the 11th slide. And I have 15 slides, so I hope I'll finish on time.
Mr. Farooq Fadarmi, you have 1 minute left to present your presentation.
Okay, so I will request 2 more minutes because I think the key to conclusions is very important when we look at this.
Okay, please.
That the telehealth or telecommunication or telemedicine has its limitations, and we must be mindful of that. These are not substitute for a functioning health system. These are not substitute for in-person access to health facilities. But what it can do is it can fill those gaps that are by evidence able to be addressed by telemedicine. So not all gaps can be addressed by them, and neither they are an alternate to functioning health system, number one. Number two, they should not jeopardize the quality. So that is very important, because now that is, we are moving faster in terms of adoption of digital technologies, but what we are lacking is to qualify whether these technologies are giving the quality to the patient that should be there. And then I think overall across the world, there is a proliferation of short-lived implementations and experimentations, be it a private sector, be it a public sector. There's no harm in it, because that is how the proliferation comes. But usually these proliferations are insight to services are not really, addressing the key gaps, or even if they are addressing, they are not giving us the clear outcome and results that are needed if we really want to expand. I think I'll skip this point of cost. You remember, we started this discussion on health inequities. We identified that there is a way to identify health inequities. There is a way to identify those populations who are underserved, and there is a way to identify what solutions should be there for tele. If we are providing solutions that actually are not either used by them or not addressed to their needs, then the question remains, are we really able to qualify the objectives that we intended the use of these digital technologies? I'll skip this 12th slide, but just wanted to give you an idea that, yes, a lot of countries are doing their work. That is, right now, even in Indonesia, there are digital health policy work going on. There is community-based work going on. But I must agree that I think most of this still is in very infancy or earlier phases and a piecemeal approach. And that is why my slide 13 talks about what WHO proposed when they were looking at the situation of COVID. As a first step, we thought that it's important to give you a bigger picture of how use of telemedicine, and that is particular telemedicine, not digital health. So please bear with me. It is telemedicine that we are looking at, how that can be used, what are the key considerations. And if you look at the left side, I'm sure you'll have these slides later on as well. And there are, for all of these slides, there are references available that you can access online from anywhere. These are free to use. So there are aspects that are needed to be considered, key considerations, before implementing a well-established telemedicine platform. And then what type of services can we deliver? And this is on the right, the potential services that we came across as a first step that might be in a way that won't require a lot of quality reviews before getting in place or into effect. And that's for those patients who might not be COVID positive, but do require those services, and especially because of the services are gone missing or are not available due to COVID situation. But just giving you an example of how the overall architecture in public health side works for telemedicine and then overall digital health. Now, how then should we make decisions for the future use of telemedicine? And that's my last slide. If you see the statement on the right, that was a very true statement, and that is in WHO resolution as well by the WHO e-health evaluation group, that to improve health and reduce health inequalities, rigorous evaluation of e-health is necessary to generate evidence. Remember that we talked about evidence, and promote appropriate integration and use of technologies. So integration means integration within the overall health system architecture. Now, just if I may summarize, key considerations of equity, inclusivity, identify the right audience, and according to the audience, the right needs that need to be addressed is very important, and is the first step. We do have platforms, but how and where these platforms should be used is important. Then functionalities of communication strategies, because you need to also inform the user how to use those technologies. And that's where usually sometimes most of the thinking process is lacking. The user e-health communication or user e-health literacy is as much important as provision of services. And then cost effectiveness, mapping out the services that would mean the best for those who are vulnerable. There's no doubt that advance in research is needed both at both levels, at technology level as well as clinical standard setting level, because still these ethical issues of using or evaluating a patient through through a telemedicine platform is different when evaluating a patient in person. So a lot of effort is needed to find out the right way and the right approach. And then local, social, legal, regulatory, and technological context, you can't skip that. So thank you very much for bearing with me. I'm available for answering any questions, and it was a pleasure to present to this forum. And I'm sure that that might be of help to the audience as well as potential users of this session.
Thank you very much, Mr. Farouk, and we can wait for the Q&A discussion. But before that, ladies and gentlemen, we are moving to the next speakers. We have Mr. Surahyo as a Project Associate of Digital Health, UNDP Indonesia, with the topic Bridging the Gaps of Telemedicine for the Future Health System. Okay, Mr. Surahyo, the screen is yours.
Okay, good afternoon, everyone. Thank you very much, Mbak Dini, for giving me time to share my experience in telemedicine. And also, I would like to thank also for the distinguished speakers in our previous speaker, Pak Irwan, Pak Ciprianus, Pak Setiaji, Pak Oscar, and Pak Farouk, who gave insightful information about the telemedicine, all the challenges and opportunities, and many other things. So I would like to share my presentation directly from my notebook. So please give me some time to do this. Okay. Yeah. Can you see my slide clearly here, everyone? Yes. Yeah, thank you very much. Yes. Thank you very much. I was given the title of the Bridging the Gaps of Telemedicine for the Future Health System. So here, maybe I would like to give some presentation about the more narrower topics about what kind of the telemedicine is already implemented in Indonesia and what kind of gaps exist there, because there are so many type of telemedicine actually running now in Indonesia, from using the high-tech technology and low-end technology as well. So here, maybe afterward, we can see the bigger picture and or the complete map of the telemedicine ecosystem in Indonesia. Yeah. So before that, I would like to share you about the background of Indonesia as well. As you know, we are in archipelago countries. We have 17,000 islands, and unfortunately, the distribution of the hospital in Indonesia is unevenly, as you see in the slide. Most of them are in western area of Indonesia. So meaning that here we have still a lot of homeworks to improve health services in eastern and also central of Indonesia. So if we want to improve it by building or developing the physical facilities, maybe it takes time and also a lot of money should be used there. So meaning that maybe we would utilize the technology to help all our colleagues and the medical doctors there to give a better service by using technology which is called telemedicine, which is also in narrow meaning is for the teleconsultation here. As you see here, also in the next slide, you see that the distribution of our specialists as well also uneven. We can see that most of them are also in western of Indonesia, especially like pediatric, obstetric, and so on. Then all of the GP who works in primary healthcare in eastern and center of Indonesia, they need the expertise using the telemedicine by using the teleconsultation function. Even with very simple technology like maybe WhatsApp, and also we can use the higher technology using some kind of technology. So meaning that I would like to remind you just to refresh on the meaning and the definition of telemedicine itself. As you see, if we look at the telemedicine by WHO 2016, it simply says that delivery of healthcare services where patient and the provider are separated by distance, and it can use ICT or information and communication technology for the diagnosis and treatment of disease and injuries, research and evaluation, and also continuing education of health professionals. So if you're talking about ICT itself, according to the ITU 2016, you could also use very simple technology using radio. I think I've witnessed it by myself, to people who lives in rural area, using the 2-meter radios to communicate each other, to give some expertise from another specialist, because there is no 2G or 3G mobile communication. They just use the mobile radio communication using 2-meter radio, and it works well. So meaning that, yeah, we're talking about technology. So in Indonesia, there is a big gap from very low-end technology using radio, or maybe we can just internet using some high-speed technology using 4G connection and many other things. So then I would like to remind that telemedicine or teleconsultation or telehealth services in Indonesia, we still have a lot of gap or big gaps among them. So then I would like to share some data or experience that we have been working as a UNDP, and also we are very happy working with the Ministry of Health, especially with the DTO and the Pusdatin for the several years, and we really appreciate for the achievement that they have been doing until now, something like that. Yeah. Then here, if you see, if the telemedicine service in Indonesia, according to WHO as well, there are two kind of telemedicine. One is the provider to provider, and the second one will be a client to provider telemedicine. So if we have been focusing more in government side, actually at the moment, the government or Ministry of Health already has the Temenin or Telemedicine Indonesia. Just recently, it just changed the name to be Komen. And also we have integrated a referral system or Sisruta. It works among the healthcare facilities. If also talking about private hospital, there are also many provider to private telemedicine as well, but I cannot mention here because so many. But if we're also talking about the client to provider telemedicine, the government itself already has a CLPDIA. This is run by the Ministry of Health at the moment. Mobile VKN is run by the BPJS Kesehatan. And please do not forget, also during the pandemic, there are many new function extension from the hospital information system to serve the patient who cannot come to the hospital because of the COVID pandemic. They are already a registered patient who has already electronic medical record there. Then we also use this kind of telemedicine as well. Like just for example, one is called Tekon in Sarjito Hospital in Yogyakarta. Also there is an RSCM Jakarta and many others. So there are also a lot of telemedicine services provided the hospital to the existing client or existing patient using some kind of technology, even just simple one like using WhatsApp technology, or maybe just give some new module or function on top of the hospital information system. And also, please do not forget that there are 1,000 of the primary healthcare also trying to serve all the patient using some technology because of the pandemic, that they're now to see each other physically or directly. Then they just use very simple one like using SMS short message services. Also, you can use the WhatsApp, some also Line, and many other things. This is also called the telemedicine. Again, we will see the gaps of the technology here. And of course, we also have our partner here, ATENSI, are providing a lot of telemedicine services with a lot of members there with high technology that can use for the teleconsultation using mobile application on the smartphone, using 4G communication and other things. It's already sophisticated technology. Some of them already using artificial intelligence, bot chat, and many other things. So again, if we see on this slide, you can see the gaps among the telemedicine services in Indonesia. So please let me start with this telemedicine provided by the government, this Ministry of Health. It is owned and developed by the Ministry of Health Indonesia in 2017, but actually the Ministry of Health already started this project since 2012 using some technology for the simple one, the tele ECG and radiology, and they improved in 2014 with teleradiology as well, using some private sector. And in 2016, they also improved the integrated system using tele-ECG, USC, and closed sources. But in 2017, they decided by themselves to develop and to build the Temenin or Telemedicine Indonesia. Now it became Comment, the name. And yeah, this is just why I present here, just the example that this the services already there and also supported by the government regulation, which is Ministry of Decree number 20 in year 2019. So it just show you what is happening there in the telemedicine service among the healthcare facilities. Yeah, it's not from the healthcare to the patient directly. Yeah, and again, this is just shown a number of the use of the teleradiology, because actually they have only 3 basic functions: teleradiology, tele-ECG, and tele-USC. Also plus the teleconsultation. It can be used for many kind of services as well. We're trying to understand more, because maybe in the future, maybe UNDP can give some support also to improve and to give better services, especially to reach all the remote and rural area for the people who work in primary healthcare, especially in Eastern and Central of Indonesia. So here, the number of the teleradiology use is quite high because it's I think it's already did there. It shows you the demand of there, but the ECG is still low. It's just like 200, 500, and so on. And even the USG is very low, meaning that if you're talking about the healthcare facilities to support, let's say, for the pregnant woman, for the babies, and so on, then we need to improve more. We have to support more how to use the tele-ECG more efficiently using this kind of technology as well, right? And this is also the this audit I borrowed from the Ministry of Health, from the Directorate of from the Health Services, yeah. And if they show you that actually demand already there, the utilization is already there, but maybe in the future there needs some improvement to have more or to get more GP on the primary healthcare to be supported by the specialists in a district hospital as well, something like that. Yeah, and it's just showing you the area that they are already very active using the telemedicine, which is Temenin or Comment right now. The Parapat Hospital in the Sumatra, in Supyori in Papua, Tonjong and Karanganyar in Central Java, and many other things. So when I show you the specialist doctor who serve a lot in telemedicine, they are very active. Also, maybe there is some motivation why they are very active to support all the consultation from the rural or remote health services, like the primary healthcare, right? It's from Adamali Hospital, from BIA, and many other things. If you see all the district or city, it gives us a picture that this telemedicine is already there. It's running also well. We cannot running well, but it works good. It helps them, especially the GP in the primary healthcare, to have the expertise from the specialist. So then, yeah, we need to explore more to support them more to get better reach to more rural area or remote area that need to be supported by telemedicine services, something like that. So you see it's not already in North Sumatra, in Papua, in Lampung and Sumatra as well, Riau, Maluku, East Kalimantan, Jambi, and many other places. So here is one of the example run by the government, which is Ministry of Health, in area of telemedicine for the healthcare facilities, among the health facilities. So this is also some pictures showing that challenges in rural and remote and rural area in Indonesia. As you see, we also need more about the medical device to be integrated to the telemedicine services. Either it's for telemedicine, maybe or for mobile JKN or many other things, maybe also in ATENSI group who are trying to reach the remote and rural area. There are also still some challenge how to integrate with the medical device like here in tele-ECG, or we can use some CR, computed radiology. This is a cheaper solution to scan the high resolution X-ray film, rather than we have used a digital X-ray is very, very expensive. And we also see the challenges about the internet connection, because again, even the Bhakti with the Palapring already expand on the backbone of the fiber optic to everywhere in Indonesia, but still in that area we need more access using a lot of BTS provided by telecommunication provider to give better connection or communication. Again, this is also still of a challenge or homework for us to improve all the ICT or telecommunication services if we want to use the technology to support the medical doctor or the nurse, or maybe in remote area using some kind of network technology to conduct the teleconsultation service like here. There's some picture like in South Sapor in West Papua. It's very, very remote area. We have to take like 5 hours from Sorong. In Tionggohang, Makamulu, we have to take 7 hours from Samarinda. Then by boat on the Mahakam River, we have to travel like 8 hours by boat to reach the Tionggohang in Mahakam. There are so many infrastructure challenge as well, and in Indonesia, and then we have to get more support from the telecommunication provider to expand their reach. So here, as you see, actually Kominfo and Bhakti is very seriously developing their project Palaparing to reach all the areas in Indonesia, giving the backbone area using fiber optic. But still in this area, we need to get more about the like BTS, the provider, the tower, to reach all the people there. There are also many actually what's that alternative solution like using VSAT or the satellite, but again the satellite is very expensive and also very low and a big deal out there. If you see here in UNDP as us, we have been working also with ATENSI to conduct some assessment. We did it in 2020 and 2021. We did this final assessment telemedicine service in pandemic situation in Indonesia, and the report is already finalized in 1st of March 2020. I will give you some results afterward. And also, of course, just recently, UNDP also is supporting the Ministry of Health to develop the digital health transformation blueprint, and it was launched in 16th of December. And we still are working from the roadmap and strategic direction, and many other things will come in the future to support the digital health transformation in Indonesia. So as you see here, based on the assessment with ATENSI last year, we see that the result like here, the most accessible telemedicine service was the teleconsultation. The second one was the health article. And the third one will be online appointment, many other things. And also, again, we're talking about the remote and rural area at the moment. Still, the region with the highest telemedicine user for the ATENSI group still in Western area, like especially in DKI Jakarta, in Java, East Java, Central Java, and we are dealing some of them already also in Sumatra, Bali, and Manila. So we still have homework, still have many things to do to reach in remote and rural area. And also, interestingly, the user demography by gender mostly are from women. Maybe it is also like a tradition in Indonesia. If talking about the health, mental health issues, usually will be handled by the mother or maybe someone who will take care in the family. And of course, also the user of education, because this is like more in running in smartphone application than the user education background, mostly from people who are graduated from bachelor, S1, and some of them are senior high school. So we still have some area that in talking about the digital literacy, especially in rural and remote area, how we can improve people who, let's say, only have education elementary and junior high school to use the technology appropriately, especially for to get the digital health services, something like that. And as you see here, based on this our assessment, it says that the
Pardon me, Mr. Surahyo, you have 3 minutes left to present.
good. Okay, yes, I think almost finished. Lack of regulation, I think we did it all in our previous webinar as well. The human resource as well, again about the infrastructure, and also we need strong support from the government, from the regulation. We also did also in the previous webinar. The readiness, we need to conduct some survey on that, and the payment model, we also conducted in the previous webinar with BPJS Kesehatan about how we can do financing for the telemedicine service. Yeah, the Minister of Health just recently with UNDP as a supporter, we launched the strategy transformasi digital kesehatan in 16th of December. And I think Pak Oscar already also explained that they have priority as well in telemedicine and Group C, saying that expansion of telemedicine technology. So then they have a high priority in improving the telemedicine services in Indonesia. Also, I borrow from the AMO, this is a partner of the JICA. They also already conducted a study recently to map all the telemedicine services or telemedicine ecosystem in Indonesia. We divided into 3 groups. One is from public with Minister of Health, public from the BPJS Kesehatan, and the other is from the local health company. As you see, there are some group like from user, from general public, from patient, puskesmas, or primary healthcare and public hospital. It says some remarks saying that CRPDA is still limited exposure by public, long response time. Feminine is also limited functionality, slow integration with the medical device. This is also another issue that we should cover. And the referral information system, mobile JKN has wider outreach and more users than CRPDA and feminine. It has been used in primary healthcare, especially for the GP to serve the patient who lives in rural area using mobile JKN in the user and using mobile JKN Vaskes in the primary healthcare. It also Peduli Lindungi, this is most active user, it's like 70 million or maybe more now, I think mostly in 90 million user. And on the private medicine, private telemedicine, it also has remarks about network infrastructure and logistic barrier, less incentive to cover the rural and remote area since BPJS do not cover the fee for private telemedicine services. And there are still few users in rural and remote area because it's not been socialized anymore in maybe urban and big city and many other things. The last one is also saying that, yes, actually, there are many kind of telemedicine in Indonesia. If we refer to the WHO, as you see, the will be divided into mobile health, wearable sensor device, data science, and so on. It's also in a group of client, patient, healthcare provider. Yes, we have some, but we need more. Here, the last slide saying that things to do. I think the message is, firstly, we have to conduct the complete mapping for all telemedicine services in Indonesia. Then we also must provide the strategic framework. We should have the ethical and ethical practice in providing telemedicine service. Government support toward the general operating guideline of the services. Coordination among the national institution or state authorities, and with the private sector, especially like ATENSI, international provider, in regulating the guideline for telemedicine practices. The last one, we also need the public perception resources toward telemedicine based on research finding or community survey. We haven't done yet. This is our homework, what we did with ATENSI last year, and how the certification level after using the telemedicine. I think that's all, Mbak Dini, from my presentation. Back to you. Thank you very much.
Okay, thank you very much, Mr. Surahyo, for your presentation. So, ladies and gentlemen, we are moved to the next agenda, Q&A discussion. So, if you have any question in your mind, please feel free to to text on the chat box. Jadi kalau misalnya Bapak dan Ibu sekalian ada pertanyaan, silahkan diketikkan dalam kolom chat box dan jangan lupa sertakan dari mana berasal dan juga ditujukan kepada siapa. Dan satu lagi pengingat dari saya, kami menyediakan untuk fitur interpretation. Jadi kalau Bapak dan Ibu agak kesulitan untuk memahami, kami menyediakan dua bahasa Inggris dan juga bahasa Indonesia. You can click the globe button on the right bottom on your Zoom screen, so it will help you to memahami diskusinya seperti apa ya. Boleh kalau begitu kita lanjut kepada sesi discussion, maksud saya. We have Bapak Daniel Oscar Baskoro, Mr. Daniel, Mr. Faruk, and also Mr. Surahyo. Okay, so we have the three musketeer here, Mr. Faruk, Mr. Daniel, and also Mr. Rahyo. We have several questions from the participant here. So maybe the first question, it's come from Mr. Didit from University of Brawijaya. This question is supposed to be to Mr. Daniel. Mr. Didit, as Mr. Daniel, during the implementation of integrated health services platform to be expanded and accessed nationwide, what is the national regulation concern to the privacy data? It relates to data which rely to international or regional regulation. Maybe this is the first question. Mr. Daniel, can you answer the question directly?
Yes, thank you, moderator, for the question, and also Mr. Didi for the question. For the question about talking about the data privacy related to the telemedicine. So I want to answer about this basic concept that the currently the global regulation, the policy about the telemedicine is we are all countries I think are referring to the GDPR regulation.
Okay. The
GDPR regulation is a baseline for the how we protecting the data, including the personal data. And from that baseline, from the GDPR and also other regulation also related to data privacy and also data protection. So this is the regulation should be the baseline for the many startups and many products related to telemedicine. So that's the basic concept. So when we develop the project related to telemedicine, they need to comply with that regulation, the GDPR, for example, or also other policy also. So there are some standard on that. But Indonesia, we are currently don't have any specific regulation related to personal data protection. The regulation there, but still in the development.
Okay.
And still development, not specifically for the health, but for the general purpose for the data protection. And once it's done, once it's done, the regulation, we will referring to that regulation. Just the future goal, But while the regulation not yet done, not yet there, please refer to many regulation and policy related to data protection, especially for GDPR. The basic concept is about the consent, for example. If you need to use the data for many purpose, please make sure you have the consent on that. So people can understand how the provider, how the system or the startup use their data. Just the basic concept for the practical use there. And also related to that, the upcoming regulation for the telemedicine for public, we are also will address on that issue also. So we're not yet defining any specific terms related to data privacy in our concept, and we will consider on that. But basically, we will refer to the main regulation on the data protection from the national government, and then we'll going drop down in the specific regulation of telemedicine, and that will be related with its other regulation. So hopefully that's answered the question. So the basic things, the two aspects. First, we not yet have the regulation related to the data privacy, and please refer to the global standard on the data privacy, and make sure you refer on that. The first thing. So don't forget to refer. And then the second things, in the practical implementation, don't forget always put it the consent in any collection of your personal information in any feature and the services. If you are having the services related to collecting data, especially for the telemedicine, I think there's a lot of data collection on the personal. Yeah.
Okay.
I'll back to the moderator. Thank you.
Okay, Mr. Daniel, thank you very much. So I think if I'm not mistaken, regulation is already exists, but it's still underdeveloped, like Mr. Daniel said. Okay, maybe the second one is I just want to know, Mr. Farouk, your opinion based on your presentation or based on your experiences about the privacy, about the data privacy. Is there any comment from the privacy data in telemedicine from your country, by the way?
Well, if you would want to, I think the regulatory environment is by the countries.
Data privacy.
And that does include data confidentiality and management. But it's not only in terms of, because sometimes again the terminology becomes too simplified in terms of confidentiality. The issue with data confidentiality is not only in terms of ensuring the secrecy of the data or of the persons, but also ensuring how the data is being used and how the data is being entered into interoperable system of digital health. So the regulation is not about data confidentiality, but regulation is also about the digital technology, the use of the digital platform, digital environment. Okay. And that's where I think that while Papa Daniel were mentioning about the existing regulations do talk about these confidentiality issues, but the existing platforms are still deficient in terms of ensuring that the digital platforms are devoid of any potential of loss of data or leak of data. And that would be meaning for patient health records, for transferring of records, for even for surveillance purposes, and even for using those to count in overall health system surveillance. Well, your question was about my specific country, because I'm probably representing on behalf of the organization, or so I didn't.
Based on your experiences, okay.
Yeah. Mm-hmm. And that is why most of the countries right now are at the stage where they are trying to ensure that this element is one of the major component in any digital health transformation regulatory environment.
Okay.
Yeah.
Okay, Mr. Farouk, I believe that you say about the benefit of digital health. You have improving access and then increasing financial efficiency, supporting and expanding coverage for UHC. I believe that every country has their own uniqueness, has their own way to face the disruptive era and also the digital economy changes. So if I'm not mistaken, you mentioned the fourth benefit of digital health. How we can gain the benefit of digital health, this fourth of benefit? I mean, like your opinion about this. How Indonesia can learn about to raise and to gain the benefit of digital health. Maybe you can give your own opinion to this, please, Mr. Farouk, before I move to Mr. Surahyo to answer another question. So, Mr. Farouk, please, the time is yours.
So I can quickly answer this in the shortest possible way. If you realize overall, when we look at the global health architecture or health system architecture, that also has a lot of differentials across the countries.
Yes, indeed.
But then, what does it mean to the digital technology? If a country that is well advanced in use of digital technology compared to the country that might just have a few telemedicine services, let's say mobile services, simple mobile services, or their penetration of internet is not really good, then where should they go? That is why what WHO has done is developed a global strategy on digital health. And that strategy is not talking about very specific specificities of interventions, but what it is talking about is specific of the strategies that the countries should adopt according to their existing technological status or existing economic status. And then they define the interventions and the mechanisms. For example, I think one of the interesting examples is from India. It's a huge country. It's a low middle income country. But then while there might be internet users and mobile penetration, the idea of reach out was more important to the government than idea of the type of technology. So what does it mean? That when they initiated an M cessation program, mobile cessation, that is for tobacco cessation, and they didn't create an app. What they created was a platform of SMS messaging. That was an automated system that registered users, and then the users were able to automatically receive on weekly basis the instructions or messages. So what I mean to say is that according to the country situation, according to the target audience, their affordability and their knowledge of the health literacy, the targeted approach has to cater all these elements. So you don't need to tell a vulnerable individual that you need to have a smartphone to avail the technology that is available, but you have to create the minimum possible way where you are able to reach out according to his or her affordability and availability. So that's where the flexibilities should be there, and that's where the global strategy on digital health talks about those flexibilities.
Okay, thank you very much, Mr. Farooq. So every country has their specific strategy, and then also probably have a different mechanism to face the digital telemedicine improvement. Okay, we are moved to the next question. It's come from Dr. Santi. I think I'm gonna ask to Mr. Surahyo, because the procurement of telemedicine platform is very expensive and complex. Can the doctor join the Cares Protect network in one platform, which is a virtual clinic that managed by the doctors themselves? Maybe Mr. Surahyo, you can answer the question directly.
Yeah, I think it will be possible. I mean, nowadays it's talking about the cloud technology, but the platform is already there, and maybe the medical doctor can just utilize, become a member of that kind of services, and then yes, I think it's very, very possible to do that. The technology will allow to conduct it. I think member of the ATENSI also will very helpful to help them to
be able to
provide
join.
it. Yes. Even also in some hospital who has some already good telemedicine services also is able to solve the problem, I think.
Okay. Okay, Mr. Surahyo, I have a question in mind. So based on your presentation, you say the data about the highest number of consultation is coming from Simalungun, from North Sumatra. Is there any opinion, your opinion based on this data, Mr. Surahyo? Because this is very curious about the highest number of consultation. It comes from North Sumatra, from Simalungun. Okay,
Yeah.
Mr. Surahyo.
I think it's based on my experience as well. Not before that, related to the data from the Ministry of Health, because sometimes I would discuss with them from the General of Health Services. It was from the Orange Bari in Papua. So meaning that usually the why the highest number of telemedicine service is from that kind of area is because of the doctor itself is very active.
Okay.
It's very helpful. He or she likes to participate more in the telemedicine. It's usually, based on my experience, based on the person who runs or to serve the telemedicine service there. It is based on it because the previous data was from the Orange Bari in Papua Barat in West Papua.
Okay, thank you very much, Mr. Surahyo. It's very interesting. Women are still the highest number of the consultant number. Okay, I already asked Mr. Farouk for 2 questions and Mr. Surahyo for 2 questions, and I'm going back to Mr. Daniel. So Mr. Daniel is, I have a question still from Mr. Didit from Universitas of Brawijaya. The second question is, what kind of privacy data cannot be exchanged or stored through the cross system with telemedicine use, with the server store in national or foreign country?
Okay, so yeah, the basic information about the data storing, yeah, related to health information, yeah, we can refer about the health medical record. So that's the basic concept of the data storing and also data management on the health medical record. So in the current situation, yeah, we will launch, yeah, in the next following weeks, yeah, the regulation about the electronic medical record. So we will have the guideline and the policy or related to electronic medical record. We already have the final discussion and also final draft, and will be launched soon on that regulation. And the basic information about data sharing is also data storing, yeah, is related to the summary of the patient data. So the data sharing is not all about the data about the record of the patient, but the summary of the patient that can be shared to other entities. That's the first thing. And the second thing about the host, where's the location? We want to put the digital transformation, yeah, that we already explained, is related to the platform as a services. So we inspired by the UK government, how they make the digital transformation health. So they put the platform as a service as a key. Why? Because if you put government as a final destination of data, yeah. So as a final data location, it's not possible for the health especially. Because why? Because that health data is very big. From the medical record, yeah, we can see the data based on the number, based on the text, but also there's a data on the X-ray, on the imaging format. That's why if we store all the data in the central government, that's not possible. We need to have a very, very big infrastructure to support that. And that's why we built a platform as a service. So we not store all the data, but we have the bridge, we have the API to connect the system, to connect the platform with its health facility. So its health facility own their data, but if we need the data, for example, for the policy making, for example, for travel purpose, for example, and also an important thing about the crisis situation. So we need to prepare the future pandemic, right? In the future pandemic, that we can learn, yeah, from the previous pandemic. We cannot get the data. We don't have the data. We have a very complicated process because we don't have the how we can collect the data. So we built this platform. So anytime we have the critical situation, we can call the data. We're not collecting data every day, but we can call the data every time if we need for the critical situation, for example. So just to answer that, I want to answer about the question. Yeah, the first thing, the policy about the electronic medical record will be launched soon, and the data sharing specifically will be focusing on the resum of the health medical record, not all the data, the open data sharing. The second thing about our approach to integrate the data by using the platform as a service. So not collecting all the data, but we are creating the bridge. We are creating the API to call the data anytime we need, anytime we use, especially for critical situation. I think that's all from me. Thank you.
It's probably the last question for Mr. Daniel. It's come from Dr. Nico. After pandemic, what next for the telemedicine project, Pak Daniel? Are there any plans already? How did the government platforms, stakeholders, and private?
Yes, sure. That's very interesting about telemedicine. So what we learned, yeah, from the pandemic, we're building the policy for the telemedicine for the social patient just only 1 week. This is the good example, yeah, about the policy making. Actually, in the usually, in Indonesia we call it the power of kepepet of deadline power, right? Yeah, okay. Because health aspect is about life, right? So we cannot wait like for a long time to develop a policy that related to health, related to life of the people. Right? So in this year, we want to expand the policy that already used right now. Yeah. I think thank you so much for the ATENSI to support on this implementation of the policy, so we can make this happen. Policy, not only policy, but also the good benefit for the citizen, our citizen. And we want to expand this not only for the pandemic, for the COVID-19, but we will expand to many other diseases to telemedicine. Pak Surahyo already explained that we already have the regulation related to the health facility to health facility telemedicine, but that's not enough, right? The request, the needs of the user is about the telemedicine to public directly, and we want to develop on that. And the second things, we will develop the policy. But the second things, important thing also about integrating that into the ecosystem of the industry, right? So we want to enhance, we want to expand the number of the telemedicine staff. Currently, that's supporting the telemedicine for the COVID-19, it's just only 17. And hopefully, if anyone wants to create the startup, create the industry for the telemedicine, please do it. We want this because this is very important. We have 270 million people, and also we have 50,000 islands. If only 17, that's not enough. So we encourage all people, all startup or industrial to build the telemedicine and help us to put the telemedicine as a key services for the health sector, as a primary. So our goal is also to put the telemedicine as a primary. So we want to make sure people not only thinking about, oh yeah, if I got sick, I come to hospital or come to puskesmas, but we want to change the mindset. If I got sick, okay, I use the app to call telemedicine. So that's the second thing. We want to change the mindset of our citizen to use the telemedicine as a primary tools for the services. And the last one, this is also an important thing. We are on discussion to make sure the financial aspect of the telemedicine is also covered, right? This is an important thing. Okay. Because the telemedicine is only about the service, but also how we can make sure the telemedicine is covered by insurance. This is very difficult, but we need a lot of support from the ecosystem together to push on this. For example, I just come to the conference in the Orlando last 2 days, currently in New York right now. In Orlando, we hear the good practice from the US government. They put the insurance for they integrate the insurance from the government to the telemedicine, but they start in the rural area. So any telemedicine that used in the rural area, that's covered by the government. So that's extend also enhance the level of the quality level of the telemedicine. So the rural area want to use telemedicine because it's free. So the U.S. government starting on that. So that's a good example from the U.S. U.S. about integrating the government insurance to the telemedicine starting the rural area. And we are thinking on that also, but this will be a long process for the insurance. But we need to support. We need the support from the ecosystem and also the communities to push that because that's important. So the aspect in the future of your telemedicine.
Okay.
Yeah. Over back. Thank you.
Thank you very much, Mr. Daniel. Actually, I have one question before move to the session 2, to the second session, to Mr. Farouk. Actually, I have one nice conclusion from Dr. Santi. That's all about. Wait. Oh, okay. In telemedicine ecosystem, so we have 4. The first is government. First, 4 actor. Like the government, and then the third party to keep the data collection, and also the doctor or the hospital, and the fourth one is for the user or patient. Okay, maybe you have your own opinion, Mr. Farouk. Is that you agree with this conclusion from Dr. Santi? If we want to build the great ecosystem.
I think I did give this answer. If you see any of the health system, the private service providers and the government service providers are always there. So you will not be able to distinguish, or at least to say that, the telemedicine or any system has to only to be owned by the government. Unfortunately, that doesn't happen anywhere in the world. Now, but what is important is two things, and that's what I alluded. One is the regulatory environment on the digital system itself. That includes the data management, that includes all the regulatory principles that any private or public healthcare provider. But the second thing is important, and that is the public health science. I think the whole gist of my presentation that I focused on was, whatever we are trying to give services through, whether through a private system, whether through a public system, yes, there is a government that should be a regulator. There is a patient or a end user that would be there, having a possibility to avail any of these mechanisms. But then the principles and the standards should be maintained. And that is where the second role is, that in terms of public health science, the type of service provision, the quality of service provision, the uniformity of service provision, and the quality standards are where those protocols and mechanisms and regulatory systems are needed, in addition to the digital health regulatory systems.
Okay, thank you very much, Mr. Farouk. So I want to thank to Mr. Farouk and also Mr. Surahyo and Mr. Daniel Baskoro. Thank you for your time. We are going to move to the second session. So for all speakers, if you are available, please stand by until session 2 to the second session in the Q&A section, because we will begin to the panel discussion for now. Okay, thank you very much once again. And ladies and gentlemen, we are moving to the next session. Ladies and gentlemen, without any further information, we will enter the panel discussion session with the topic Building Resilient and Sustainable Telemedicine Services during the COVID-19 pandemic and also for the future. We have special speakers here. We have two special speakers because Mr. Sahzad from the Pakistan, from the latest information, was on a mission in another country. So I guess his situation enabled him to join our event today due to the connection or other issues occurring. But we surely look forward for other collaboration with the Pakistan government representatives. So now we only have two speakers here, but I'm sure even only two speakers here, our discussion is going to be more fruitful and also more beautiful today. So the first one is we have Mr. Jeff Parker as a Managing Director of GP Consulting from Australia. Hello, Jeff. Good afternoon.
I have to be unmute. Okay, great. Thank you. Hi, Budini. Thank you very much. I'm great. Yes. Thank you.
Okay. Thank you, Jeff, for joining with us. And the second one, we have our second speaker is Dr. Adel El Taguri from Libya as a Director General of the Center for Accreditation of Health Establishment from Libya Ministry of Health. Hello, Mr. Taguri.
Yes, hello.
Hello, it's nice to meet you today.
Thanks a lot.
Okay, ladies and gentlemen, so I've got the information that Jeff has wanted to present something, Jeff. So you have around 15 minutes to present. So I hope that Jeff has 15 minutes to present their presentation. So Jeff, the floor is yours. Okay, hello, Jeff.
Thanks very much. Good, I'm unmuted now. Thanks very much. Yes, thank you very much. I'd just like to thank you very much for inviting me to be a panelist today. It's a great honour. It's a very important event. And I'll pay my respects to the fantastic speakers and my other panelists, who I only just realised there's 3 of us now. I have prepared a short presentation, if that's okay to run through. Can you all see that okay?
Yes, I can see very clearly, Jeff.
Okay, terrific, thank you. I might just put this here, yeah. So I'll just organise my screen, might be a second. Okay, so I guess the first point I'd like to make is that, you know, I'm in Australia, but I'm not speaking on behalf of the Australian government. So I think that it's important that people appreciate that what I'm speaking about is my opinion, but based on a long experience of doing consulting work in the digital health space, and particularly in healthcare. I'm a healthcare consultant. I run a healthcare consulting business here in Australia called JP Consulting. I'm also a fellow and certified health executive of the Australasian College of Health Service Management, and a fellow of the Australasian Institute of Digital Health here in Australia. And also an interesting other additional role is that I'm the chairman of the healthcare group of the Australia-Indonesia Business Council. And I've put links on that page there for people who might be interested. It'd be handy just to have a quick description of the Australian healthcare system so that people are aware, you know, maybe of what the differences are between Indonesia and Australia. So we have a population of 27 million people, so we're a tenth the size in population from Indonesia, but we've got one very big island, if you like, whereas Indonesia has 17,000. So importantly, the health system's funded largely by the government, different levels of government in Australia. You can see the differences there. Private health insurance, about 9%, and individuals contribute to the costs of healthcare in Australia too. And I mention these because they're relevant to how funding aspects work in telehealth as well. So we have, you know, healthcare expenditure in Australia is about 10% of GDP, and we do have a universal healthcare system that's called Medicare. Basically, the primary care, GPs and specialists are predominantly funded by the Federal Health Department. The state and territory governments mainly spend their health investment in community health services, but they're the main driver of the public hospital systems in Australia. And the private health insurers also play a key role in the private hospitals. The federal government also invests a fair bit in research, health research as well. In terms of the telehealth landscape, and I might just mention, in Australia, we prefer to use the word telehealth, and it was pleasing to hear Pasarayo give the definition, the WHO definition of telemedicine, and indicated that telemedicine and telehealth are basically interchangeable. I think part of the rationale for us deciding here to use telehealth instead of telemedicine is to, in a way, downplay the medical model that's you know, at play, if you like, with this form of care delivery, so that we could encapsulate other forms. So, you know, encapsulate prevention, some of the social care dimensions, wellness, the digital therapeutics, etc. So telehealth is used in preference in Australia. The main players, so the Australian Federal Health Department, they have developing, about to be released, a Commonwealth Digital Health Blueprint. They mainly look after the primary care and the aged care part of the system. The state and territory health departments have their own digital health programs. I mentioned they predominantly run they do run all the public hospitals in Australia. We have an entity called the Australian Digital Health Agency, which is an external arm of the Federal Health Department, and operates relatively independently. And it has the responsibility for the National Digital Health Strategy. Now, you might ask, how come the Federal Health Department has a digital health blueprint and why is there a national digital health strategy? And it's important to appreciate that the Federal Health Department sees it having a distinct role alongside the roles of the state health departments and the private sector. So they felt it was important to be able to express their positioning and ambition and plans, etc., for digital health as a part of a national approach, which the Digital Health Agency is driving. Another key player that's very relevant for telehealth is Health Direct Australia. In amongst a range of other things, a bit of particular relevance for telemedicine is that they provide a national health services directory. So we have a single point where key data about all of the service providers, all of the services are available, their addresses, the types of services, the times they're open and specialities and so forth. So that's quite an important piece of the infrastructure that we have in Australia. And they also provide a video call service for predominantly GPs, but also the states and territories use that as well. There are private commercial platforms and providers, and I've just made some notes there about where the uses are mostly made on those platforms. And I guess the critical component, and it was great to hear this, the discussions previously by Daniel and the other speakers about the landscape in Indonesia, because I think we're all grappling with this same question about the architecture. How do we encourage innovation and get good solutions out there that do some good for the consumers and the doctors or the clinicians, while also trying to maintain an integrated and provide some protection as well to data and the quality of the care that's provided. The main accreditor in Australia is called the Australian Council on Healthcare Standards. They have an international arm, and one of the things that they do is accredit telehealth services, and there's been a number of telehealth services in Indonesia that have been accredited against those standards. Just a quick overview of what the status is, if you like, of telehealth use in Australia. Like most countries, COVID drove significant uptake. A lot of us have been in this space for many, many years. We're writing business cases and developing strategies to try and drive the uptake of telehealth. And it took a pandemic actually to stimulate it and get it going. So fortunately, we're very able to quite quickly implement the solutions, scripting e-scripts and online bookings. And in terms of funding, the Australian government responded with a funding model so that GPs could be recompensed for using telehealth services with their patients, initially as a temporary measure during the early stages of the pandemic, but very fortunately, the Federal Health Department decided to make it a permanent feature of the funding model for healthcare in Australia in December. So from a sustainability point of view now, telehealth is baked into the Australian healthcare system. It's a standard feature or an option for service delivery. Interestingly, just yesterday, we cracked over 100 million services in the 2 years up until the 16th, 2 days ago. So 17 million people of our 25 or 26 million people have used a telehealth service, and 92,000 medical practitioners have used it as well. So in terms of some key statistics, and I don't know how this differs with Indonesia, but I'll be interested to hear. We found at the early stages of the pandemic, there was quite a reluctance by patients, consumers to go to their doctors. So we had 25% of people avoid going to see their general practitioner. We had e-scripts adoption nearly double of 2020 to 2021, also with the use of online bookings. We found that healthcare providers reported an increase in telehealth consults. Interestingly, we also found that there were some at-risk cohorts of some consumers who found the telehealth platform a better way of interacting with their care providers. So there's a benefit from it in that point of view as well. Some regional practices have reported a lift in profits, and 58% of the consumers reported that they felt accessing a healthcare service using telehealth, they felt safer in doing as well. So that was an interesting development. Just in terms of some lessons, telehealth and providing care outside of hospitals works. That was probably the main thing. We did find that we need to look at how to better integrate our public and private healthcare systems, and particularly then the coordination of primary care and in interacting with that as well. Some other key lessons was just the importance of designing around consumer centricity and the clinical flow. And that sort of design thinking drives and integration and connectivity principle and agenda as well. Pasarayo and others talked about the importance of an architected approach, and it's been critical, choosing standards, choosing the right ones to make sure that interoperability can happen, with the intention of aiming for a seamless experience for both the consumer and the providers. In Australia, we were lucky enough to have an established and robust national digital health infrastructure and a range of services. So being able to build on top of that quite quickly was reasonably straightforward. We've also found it's important that providers and industry have clarity around policy by government, and that's not just funding, but also in what circumstances consumers entitled to a subsidised telehealth service and when they're not, and so forth, and also just general guidance and support for it as well. And I think just understanding the ecosystem and the role of tech as an enabler was also important in appreciating that we've gone from telephone consults to video consults. We're looking now at remote patient monitoring and virtual care. It's a layering up of sophistication, and it's really important that we understand how that fits in with the overarching healthcare system and its ambitions. Last point, just on the Indonesia and Australia relationship. Australia views Indonesia as our closest strategic neighbour, very important partnership. We have a free trade agreement, the IA-CEPA. Our Department of Foreign Affairs and Trade has written in collaboration with Indonesia a blueprint for trade and investment cooperation. About a month ago, the two health ministers signed a memorandum of understanding, and that includes health tech within scope, as well as a broader range of health security and a whole range of other supply chain, etc. And importantly, the MOU sets about to a process of ensuring that there's plans for action developed cooperatively between our two countries. I mentioned at the beginning I'm the chairman of the healthcare group of the Australia-Indonesia Business Council, and that's just a group of organisations that have a particular interest in healthcare with Indonesia, and a lot of capability that might be relevant. So that's it. Thanks very much. I'll just stop sharing my screen. How do I do that? Okay. Thank you very much, Budini.
Yeah. Okay. Okay, thank you very much, Jeff. It's very insightful for me, especially. But ladies and gentlemen, we are moving to the next panelist here. We have our second speaker is Dr. Adel El Taguri as a Director General of the Center for Accreditation of Health Establishment from Libya Ministry of Health. So, Mr. Taguri, the time is yours.
Yes, hello. Good morning, everybody. Actually, it's morning in Libya.
Okay.
Can I share my screen, please? Disabled. I cannot share.
Okay, we still prepare.
No, yeah, I would be able to.
I think we still prepare for the presentation. Sorry for the inconvenience, Mr. Taguri.
Yeah, excuse me. Yeah. So, yeah. Is my screen shared now?
Not yet, actually. Okay. Wait, Mr. Taguri. Okay. Okay.
No?
Okay. Now we can see very clearly, Mr. Taguri. So please, you have around 15 minutes to share with us.
Yes, okay. But this is not my screen. That's from your computer, not from mine, right? So I cannot. Yeah.
So this
Excuse
is
me.
another.
Yeah, it's not from my screen, so probably.
Or you want to you want to share yours on screen by your own self?
Maybe it would be easier for me to.
Okay, okay. So this is the different material.
Mm-hmm. No, it's this. It's the same, but I cannot go to next if you like.
So you want to share your screen by your own self?
Is it possible that I thought it would be more easier? No.
Okay, I was asking the team actually. Wait.
Okay, no problem. So just do your screen. So
is it okay?
Yeah, it's okay for me. No, no problem.
Sorry for the inconvenience, Mr. Taguri.
Okay, so I would talk about mainly the telemedicine project in Libya that was supported essentially by the UNDP office in Libya. I will take it from a health system and public health perspective, like Dr. Farouk, rather than from a very technical point of view, which I could hardly get deep into. So the next slide, please. Yes, as we all know that the digital health interventions may address different health system challenges that could be addressed by the digital health applications. Next, please. Yeah, and as Dr. Farouk showed from the WHO publication, in each of the level that is towards universal health coverage that is very important for us in public health, it's the digital health interventions do have a space, and especially when there is some problems with the coverage, to having continuous coverage, or there is a problem with accessibility, and so on. Next, please. Yeah, and depending on the level of the healthcare, whether this is the primary care or secondary, tertiary, specialized, or acute care, or whether this is preventive well-being and health management, self-health management, then telemedicine especially would have a different position according to that level. Next, please. Although there are many uses for digital health, but we are mainly concerned with those who are in green color now, in mainly telehealth services, telemedicine, and health information exchange. These are only the two, let us say, applications that we are working upon currently now, We hope that the other mobile health applications, short messaging services, and mobile diagnostic devices maybe would be initiated soon in the country. Next, please. Yeah, but there was always a concern, being a developing country, what is the feasibility? We can desire to do something, but is this viable and is it feasible? And most of the arguments that we take is that health workers wouldn't be able to use them, or it wouldn't be feasible to do it. But as research had been conducted a few years back in Africa, on the level of African region, and it was evident that frontline health workers would like and they welcome the integration of digital health technology into the work stream. Next, please. In Libya, there had always been a problem with the health coverage. So many services are not available, and it's 45% of Libyans in the last few years that were deteriorated because the coverage went abroad for treatment. And 20% of doctors, they had to travel to study. Most of those who would need treatment, they have chronic disease, and they would wait for 30 days really to have a specialist, a dedicated specialist view regarding their illness. Next, please. Yeah. In 2020, by the UN Humanitarian Needs Review, it was found that half of Libyan households do not have access to needed healthcare services. Many public health facilities were closed due to war, due to underinvestment, the conflict itself. And most of the hospitals do not offer all the essential services that were supposed to be delivered by these hospitals. In addition, many health facilities had to be closed, or the receivement of service had been hindered either by violence inside the health facility itself, or maybe a violence in the road, so that the clients or patients would not be able to arrive to these health facilities when they needed them. Next, please. Yeah. And regarding the health services, although the number of doctors for the population is good, actually, even the number of beds initially, but the number of specialists, as we've seen here from what is needed in blue color, and what are really present as a specialist. So it's the specialist service, type of service, but also the nursing service that is deficient in the health system in Libya. Next, please. In addition, so with this persistent doctor shortage, it was found also with the pandemic that people would avoid coming to the health facility when the pandemic started. Actually, there was let us say, a panic reaction when the pandemic started, and we closed almost everything very early. And in a study that had been, for example, in physiotherapy, that's why I like the option of telling it telehealth rather than telemedicine. It affected 64% of physiotherapy practice in Libya. Next, please. Yeah, and it's not only, it's the clinical approach that you use for just an example of disease, reducing the number of patients in the clinic. And it was telehealth was only used by less than 2% of physiotherapists. Next, please. Physiotherapists had also to change, to adapt their work practice changes. And then less than 1% in this change, they relied on telemedicine. And of course, the workforce itself had changed. Many physiotherapists, which are important in the management, for example, of COVID in the ICU, they didn't want to work. Many of them, almost half, either reduced or they refused working at a certain period. Next, please. Yeah, and again, the health workers, they had a poor knowledge, they had a negative attitude, and they are not practicing telemedicine. As an example, we take the physiotherapy. Next, please. Yes, so the first proposal of telemedicine actually it dated back to 1995, and there was a real need at that time because there were 2 or 3 new oil cities, full cities with good hospitals but no doctors, and they had to rely on consultants coming every week, coming to these rich oil cities, and they have to come for 500 kilometers, of course, with a lot of accidents and a lot of inconvenience because of the trajectory, the trip that the doctors had to do. In addition, some specialties like radiology, where one radiologist, a specialist, could give teleradiology is very, it was very adaptable, very useful as an option at that time. In 2009 to 2010, we wanted to start mHealth, but then this all went into vain. There was a initiative about eHealth till 2015, but again, we failed. And in 2019, an eHealth National Committee was formed. And luckily, 2020, with the COVID-19, well, every crisis has its own opportunity. And the Ministry of Health, there was a memorandum of understanding with this private group of young people who had started the first step at the same time parallel to the National Committee. Next slide, please. And there was a SPITAR, which it took the name SPITAR, which means hospital in many languages. And there was that was a good application at that. Even now, it's the single application that is there, although there are some two other applications, but to a minor extent. That's the one with the young doctors who did it with help of other association institutions that we'll talk about. That was a mobile and website application. Local, almost medical profession. It's unique. It's good for patients with low technological, financial, and health literacy. Next, please. It had many options inside SPITAR that was adaptable for our situation because this is a large surface area country with more than 2 million kilometers. And sometimes the nearest city between one city and another, or town, a village and another, may up to 700 kilometers, and it's very low density population. Next, please. There was, of course, a complex governance and risk environment because of the conflict which could pop up in one area or another, even small one, but these are very, very difficult for the health work, receiving health services. And there is another thing. There are many Libyan doctors working abroad. So let us say in UK, in Germany, United States, Canada, and some other countries. Probably we think that more than 3,000 Libyan doctors are working in Western countries. It would be useful and very smart to having their aid so they could do it in a better way, in this way with telehealth application. Next, please. We think also that the application as such would help even implementation of 4 of the 17 goals of the SDGs. Next, please. The program was implemented with a close partnership, especially with UNDP Libya, but also UNDP Digital X Accelerator, the Ministry of Health, and the National Center of Disease Control in Libya. The national COVID-19 triage process had really triggered the process, and it was useful from our point of view to make things realizable so they would see it and accept it, especially we're talking about the decision maker, the political decision makers in the country. Next, please. Yeah, there were many partners, including the UNDP, but also from Harvard Medical Schools, from some international partners, not only local partners. Next, please. The initial phase of the SPITAR was between 2019 to 2020, but I think the agreement was signed with the MOH and with NCDC. And these digital health services were very good for to be used in COVID-19, and it included, next please. Next slide, please. Yeah, it included the application triage for the cases, the distribution of resources that are important in where there was really a big problem with the resources, so at one time to another. And it also, the application had a possibility of measuring the infection rate and for the infection rate, the mortality rate, and so on. Next, please. At the end of 2020, the MOH leveled the National Response Plan, and we widened the scope of the response. So we included also other institutions to deliver socioeconomic status. And we had to involve at that time also the Central Bank of Libya, some of the banks, some of the legislators. It's because of the many difficulties that occurred during the implementation for the response plan and for SPITAR program. Next, please. Not only this, many of our patients, they go abroad to be treated in Tunisia, Egypt, and Jordan. That's why SPITAR had reached to these communities, so that to deliver service, whether, for example, to decide an appointment for a Libyan patient who is going to Jordan or to Egypt or to Tunisia, but also at the end of 2022, probably even to Jordanian patients themselves. So SPITAR had some agreements with local health authorities in Egypt and in Syria for a limited bilateral agreement of delivering service to Libyan patients in these countries. Next, please. In the pipeline, there is also the electronic blood delivery system and the national registry portal for credentials of health workers, because if you need to employ a doctor, then the credentials of a doctor working in a telehealth program are also important. Because diabetes, again, is a chronic delivery. It's a very problematic health. So there's a program that is dedicated for health service for diabetes mellitus. Next, please. So the system, next, please. So that will skip the next three. So the system would deliver service to these, so they could, it's in Arabic language, of course, they could decide where they are, and they choose, they pick up the doctor that they want or the specialty that they want. The next, please. Next also, please. Yeah, there appeared a problem with this, with the wallet, because the payment, so the doctor who would work in the system would have a payment, and the wallet payment, the electronic means of payment are not well developed. That's why we introduced the central bank and some of the banks at one stage in the discussions regarding the use of digital health in the National Response Plan for COVID-19. Next, please. Yeah, and what is peculiar in the system is that its responsiveness. It's very responsive to the expectations through the use of social media. So they deliver health education, next, please, in certain special issues. They also, it was obvious that many questions about the mental health had come up in the social work, so they had to change we had to change the work to deliver mental health issues. Next, please. Then the work had extended from only Tripoli to other cities in the country. Next, please. And also to include the diaspora or patients who are really in Tunisia, for example, through the social media. The next, please. So doctors from these countries also do participate. There was a good media coverage in many international agencies about the application itself. Next, please. Yeah, and there was also some quantitative evaluation of the work of SPITAR, and also quality, that it was published in 2 international journals. There was also a qualitative study. The next, please, where people would have their own opinion in social media. These are a copy of a picture from many people who were happy with the use the satisfaction, which is important for quality, about the use of the application and telehealth in Libya in general. Next, please. And the application had received 4 awards, national and regional, but also international. Next, please. Of course, there are challenges. Next, please, because these are next, please. So these are a common challenge everywhere, but in our situation, the challenges are mainly related to infrastructure because of the internet infrastructure itself, the hardware equipment, and here where the governmental support is essential. Next, please. And the other major challenges include the administrative engagement, because it's the political will to use this service. Even when it's present, the MOH itself is very reluctant to use it to a certain extent, of course, because of some of the legal responsibility and the financial methods of payment. A country that is coming out from a social idea of governing things, from a Simashko mainly type of health service. It came up to armed conflict with a lot of political instability and frequent changing of the decision makers. So, and of course, the physicians, it's obvious that they would need to raise their knowledge, attitude, and of course, practice, how to practice and to use the telehealth application. Next, please. Of course, the key factors of success would include some other aspects which are known. Next, please. And the next also, please. That would come to the last slide. It's obvious that there is, it's very important to have collaboration with the stakeholders in digital health. Specifically, it's the role of the bank, which had formed a committee, the central bank, to regulate the electronic payment for that case. The private practice, because there's many for good governance, it has to be one platform in the country, because interchangeability between these different platforms is really questionable from other countries. And whether this is a public or private, it has to be one dominant platform. That's what we learned in between. And that constitutes a problem, because if you want to implement a private practice at a platform at the national level, then that would create some legal difficulty. For education and training, we found this a very good, useful, and probably we should stress upon, specifically with the role of the diaspora. And it becomes, in our condition, the main problem is the political will and the way that this, the governance, because even when the instability in the country, the frequent change of decision makers, even when financing from the UNDP, for example, was available, and the technical assistant was available, with deficiency and a lot of change in the governance, things become more difficult in developing countries. Thanks a lot. I think that was the last slide.
Okay, thank you very much, Mr. Taguri, and also Jeff. Okay, thank you very much for both of you that share together about your experiences on your own country. So I do believe relate to our topic today, listen learn of telemedicine implementation from different countries. So there are so many questions here. I read the chat box, but before we are continue to the question from the participant, I have several questions for both of you. Especially how do the telemedicine services in your own country? I mean, like, I believe that every country has a different opportunity and challenges. So Jeff, first, maybe you can tell us, how do the telemedicine services in your country successfully address the challenges and also the barriers of your country public health issue? Okay, Jeff, probably you can answer the question directly.
Thanks. Yeah, I'm unmuted now. Thanks. Probably in terms of access, the Medicare system that I mentioned, it provides for free treatment by patients in general practices who choose to only charge the fee at the level that the government reimburses the doctors for. So that's called bulk billing, if you like. So there's no barrier effectively for patients who wish to use a telehealth service. If they go to a practice and they see a doctor that bulk bills. So I guess that's, usually it's funding that's the main barrier. Obviously, there's technological barriers. The preferred way of doing a telehealth consult in terms of a policy position is a video call. Telephone consults are permitted, and the reimbursements are a similar amount. So if the patient does not have video capability in their home or wherever they are, then they can fall back to a telephone consult. Obviously, there are types of consults that are better suited for that. If it's simply getting a repeat for a prescription or updating a referral, for example, that's pretty straightforward. But if there's more sophisticated interaction required between the doctor and the patient, then video consult is the preferred method. Being a reasonably rich country, we've got a pretty good penetration in terms of the digital devices, if you like, out in the population. We do have some remote areas that have difficulties with telecommunications, but they're being addressed as a matter of national priority. Did you want me to talk about regulations as well? I think there was a question there too.
Okay, thank you very much. Thank you very much, James, for sharing with us. So I think in Libya also has a different opportunities and challenges. Maybe Mr. Taguri can sharing with us.
Yes, actually, there are 3 or 4 main challenges, and these challenges had differed with the time. The first challenge that had been there since 1995 is that it was impossible technically to do it. And maybe financially supporting, maybe, of course, the technical was the first issue, and then the financing it. It came up, it took more than 20 years for us to find young doctors with the support of the UNDP Libya to financing, to do it technically and financially. But then again, the third challenge was, how do decision makers in the health sector, how do they see this opportunity? Most of the decision makers themselves, either they are, let us say, not digital persons, not going to this. So it's the generation gap also is an important issue in the country. Even when it was available, they were convinced only when there was a crisis. So the crisis of COVID-19 was an opportunity. But somehow, because of the political instability, and imagine in the last 2 years, we had 4 ministers of health, which is impossible. So that, and probably in a country like us, most of the real decisions are taken by the minister himself, not by the other technical parties. So what happens is that the implementation, let us say, scaling up the implementation, every time it's hindered by the change of the highest level decision makers. Another challenge is that the idea of having a private company doing it, because it has to be one national. Actually, we had this question, and with consultation of many experts, they were talking about one platform per country, especially for Libya. So can you do it with a private only? Well, that creates a lot of questions, because a tradition of social ideas for more than 40 years, that's not an easy option, not easy to say it, and probably many doctors would hesitate to fully participate. The other thing, why should I, as a doctor, for example, working in a hospital, why should I respond to replies or questions from the patients at the evening? Of course, I cannot depend on my salary from the public hospital. Most of the workforce are in public hospitals. So it needs to be in a private, just a form of incentive. Now, this incentive has to be regulated somehow in a country that is continuing to struggle with political instability and conflicts for 10 years. So imagine the digital payment systems are not really there. So we also will leverage the crisis to gather everybody, including the central bank and some of the mobile platforms for telecommunications, and they came to that gathering and meeting. And so we made them somehow, not brainwashing them, but to make them realize the importance of that. So I think mainly it's our work that should challenge is how to convince decision makers of the importance. But I think technically and financially, and if this happens with stability, then probably we could find the means to scale up the digital health application in the country.
So how to convince the decision maker is also important in Libya. Then probably is also important in Indonesia, actually, Taguri. Okay, we are moved to the next discussion. I mean the next question. As we know, nowadays, every country has still fight against the COVID-19 pandemics. Probably in most countries, they have the highest number of COVID-19 cases. And how about in Australia and also in Libya? How does your country's telemedicine accommodate the demand of healthcare services during the peak number? Probably Jeff, you can answer the question first.
Thank you. Yes. We've seen a very steady, in fact, a very fast ramp up early on, and now a continuing increase in take-up. And I guess now that telehealth has become a permanent feature of the funding system here in Australia, so there's there shouldn't be any hesitation about planning for it in terms of GP practices and other providers. Incorporating it into as a part of their full suite of offerings that they have for their patients. So I'm not sure that there's many barriers that at the moment that would get in the way. Of course, there are other private providers. I mentioned before in my talk that Health Direct Australia provides a video call service for GPs, and that's actually at no cost. But there are some commercial providers, and there's some talk about some other big overseas ones entering Australia as well at the moment. And obviously they need to negotiate some commercial arrangement with the healthcare provider to use their platform. And then there's the question for the healthcare provider of how do they pass that cost on to the patient? Should it be discrete, or should it be just a part of the overall cost? So that's probably something that's emerging at the moment as a topic for discussion. That's probably the main things I can think of just at the moment. Thanks, Adine.
How about the coordination, Jeff? How about the coordination among the national institution or probably state authority with the private sector?
Yes, there's good coordination. Like ATENSI in Indonesia, there are similar organisations in Australia that are associations for different types of technology providers, including in telehealth and the broader health, sort of broader IT sector. And they're very closely involved with government in terms of consultation about developing policy and plans and so forth. So, there's good coordination at that policy setting and planning level, and good cooperation in the delivery of the services as well.
Okay, thank you very much, Jeff. I will move to the Mr. Taguri. So the same question, Mr. Taguri. How does your country's telemedicine accommodate the demand of healthcare services during the peak number of utilization? Because as we know now today, we're still struggling for the fight against COVID-19 cases. So how about in your country?
Yes. There are two things here. The first is that we are somehow lucky. It's not really lucky, but because of the conflict that had been there. So even the number of travelers to and from Libya is limited, really. So if we take Huawei from China, from the city where there was the epidemic initially, to California, there is probably 8,000 travelers per day, but we just from the two cities. In our situation, we have only 8,000 travelers per month. So even the first 3 months of 2020, we had less than 3 days travelers from California to Huawei. So somehow we opted for the Ministry of Health, the health authorities, chose the mitigation strategy where there are no or zero cases. So we didn't have the first, the second wave that had been there in most of the countries in the world. We had a very limited number of cases. Actually, it was even panic because the idea was zero cases, which wasn't really a real choice, strategic choice. But we had a wave when the Delta variant was there, and then with the Omicron variant. These are the two epidemic waves that we had. Even from this beginning, the success of SPITAR, because it delivered, it said that we could help the Ministry of Health to report the number, do the epidemiological reports, pick up the mortalities by region, and ensure the delivery of protective equipment, because these were very precious in 2020. But because of some political, conflict between different institutions, it wasn't implemented. It was implemented very short period, then stopped short period. But at least we were happy that the idea is there, that would be accepted. And unfortunately, because there wasn't too many deaths at the beginning, so they didn't realize the importance of the full application that could be get used from the telemedicine itself, from the SPITAR at least itself. Of course, when the government changed twice now, the minister during the crisis, 4 different ministers, what happened is that the other mechanisms have developed, going back to paper, and this is one of the challenges that are well known. They find it more comfortable, even with a less quality, but they went back to paper reporting of mortality from COVID. So again, I cannot say that this is successful, but of course, at least we had moved somehow from a long way. And we might, maybe in a more stable conditions, probably we could capitalize on the what we already have, but it's not up to our wishes, unfortunately.
Okay, thank you very much, Taguri. And then I still have another question for Jeff and also Taguri from your country. It's probably related to some people or mostly people ask about the sustainability of telemedicine services. So there is, how about if post-COVID-19 pandemics, or when there is a recession in the perceived benefit among population, or especially in remote area? How about in your countries about the sustainability of telemedicine services? Jeff, please, you can answer very directly.
Yeah, thanks. I guess the key aspect for that is that, like I mentioned before, funding for government funding for telehealth services is now a permanent part of the Australian healthcare system. So whatever the requirement is, how much it grows, funding is available to provide for those services. So sustainability is not really an issue, if you like, in Australia.
Okay. And how about you? I'm moving to Taguri. The same question with yes, please.
Yes, I got the. Actually, although the system is essentially had been a SEMASHCO, let us say a Beveragian type, where the national health services are everything is free. But because of the shortage that became more evident in the last few years, even before COVID-19, people, they use their out-of-pocket expenditure, they pay into private from their own pocket, and many people also go abroad. So it is more, I mean, it's not a difficult decision, unfortunately, for patients to pay for the service. And here comes another aspect, and that's why it's a little bit complicated with the legislations. But we think that these services, especially simple services as some of the teleconsultation themselves, some prescription, a frequent prescription for chronic disease is the same. Probably these could be, and because on the other hand of the overcrowding in some health facilities, we think that it would be very sustainable with private practice. We think that this is the issue that we could work upon. That's one thing. The other thing, we had already moved from the COVID-19 only telehealth application to a chronic common disease like diabetes mellitus. So there's an agreement between the Diabetic Center of Tripoli with 100,000 registered patients with the SPITAR group, so that the work would continue, and people from remote areas in the extreme south, 1,000 kilometers from Tripoli, instead of coming to Tripoli to receive just the drug, so they could have their own prescription in their own place, and probably with home delivery of drugs, which is something that, again, online shopping wasn't there at all. And because of the crisis, then restaurants had started online shopping in the country, and also women buying things. I think this had paved the way for drugs also to be delivered through the online shopping. So we think that SPITAR is trying to sign an agreement with some pharmacies so that they could deliver the service. We think that it's the type of service, the role of private, the remoteness of area, the undercoverage with health services. These four factors probably we should, and of course incentives for the doctors. These 4 or 5 factors together could, if we get use of them, good use, rational use of them, probably would help sustain the system in Libya.
Okay, thank you very much, Taguri. Actually, I have 4 questions from the participant, but before I ask you the question from the participant, I have 1 question left. Actually, this is relate to lesson learned, how to improve telemedicine resilience and sustainability in the future. So I do believe that even Jeff or either Taguri, both of you has a different talk about the lesson learned how to improve telemedicine resilience and sustainability in the future. So maybe probably in Australia or in Libya has their own lesson learned. So can you share with us, Jeff or Taguri? Jeff first, you can answer my question directly.
Thanks. Yeah, I covered some lessons learned in the slideshow that I went through. And I think it's probably worth delving into some dimensions there. And I noticed in the chat there were some questions also around privacy and protection and regulation and so forth. And I guess one of the lessons that COVID sort of helped us understand better is the benefit that from having a very robust privacy framework of regulation in Australia. So we've got a lot of protections for privacy and some special provisions in the regulations for health information at different levels and what the protection is. And of course, there's also the whole consumer protection dimension as well at play here that's very relevant. So that's on the sort of the consumer and provider dimension. In terms of the provider and the telehealth platform dimension, before any operator of a telehealth service can offer their service, if you like, they must conform or prove conformance with the digital health standards that Australia has adopted. So, I mentioned before the, you're probably all aware we have the My Health Record. We have the National Health Service Directory that I mentioned before. We've got a secure message platform. We've got e-prescribing. There's a range of other components, if you like, of our national digital health infrastructure. There's importantly a healthcare identification service that's also laid on the top of this, and also a terminology service, so that software vendors can make sure that the terminologies that they use in their products remain up to date and so forth. So I think what happens is that the software vendors, and not only the telehealth providers, but in this case we're talking about the telehealth providers, they must prove compliance with those standards before they can connect their products to the any component of the national digital health infrastructure. So there's some good protection there as well. Obviously, there's still the risk of bad data, but at least the compliance with digital health standards is present.
So beside the infrastructure, you should you do concern about the data protection. And how about the human resources, Jeff, in Australia?
Yeah, same. We've got strong controls over who can provide what forms of clinical services. We have a national registration system, not dissimilar to all other countries, and there's limits to what services different clinician types can provide too. So that's all in place. And you can't call yourself a doctor in Australia. It's illegal unless you're qualified and you are registered with the national entity.
Okay, thank you, Jeff. So, Mr. Targuli, now it's time for you to answer the question. So, is there the same, same like Jeff, we're talking about the data protection and also about the infrastructure, and also the human resources. How about in Libya? How you do improve telemedicine resilience and sustainability in the future in Libya?
Yes, so the main issue is how to advocate for the case to the decision maker. That's one aspect that probably we should work upon. And this cannot be done unless we really use the WHO standards for building a national strategy and policy. I think in a country where changes are frequent, political instability, probably writing a national strategy that would be somehow compulsory, not really compulsory, but to a certain extent, at least moral compulsion to decision makers would be more appropriate. So that's a good arm that we should go forward to. The second thing is the role of private practice, but it's not only the private practice, it's actually young entrepreneurship, ambitious, clever, smart, and they could implement it, because I had a presentation in 1995 about the need for telehealth application in Libya, but I could never do anything. We could not move forward. It's only with some of my students, actually he was a student, and they managed to do this very successfully. They somehow they do it. They did the implementation, the application itself. They succeeded to do it. Of course, the role of the international organization was important, because otherwise they wouldn't be able to make this connection and do the programming itself. Now it comes to the decision maker, how to convince them for the persistent and to accept it and scale it up. The maintenance itself, the doing it maintainability, that it could be persistent, of sustainability, of course, it would need some form of incentives. And that's actually an idea in a country where a lot of social ideas background, probably difficult. And there, the role, the health system is moving to a Bismarckian with a third party with insurance. So if the insurance fund would accept the idea, and then, so here communication is important, or otherwise it would continue on a lower scale with only private practice in certain specialty only, nothing else.
Okay. So how to convince the decision maker, and also communication is the important thing to do, yeah, Mr. Taguri. Okay, so I have several questions here from the participants. So Jeff and Taguri, are you ready? Okay, the first question is come from Dr. Santi. Okay, this question is for Jeff. This is for you. What is the legal settlement system in your country if there is a problem in telehealth between user and also service provider and other related parties, if one of the parties in Aussie foreign citizen, where the outside party use a legal system based on the location of the victim? So this is related to legal statement system in your country, actually.
It's really not different to any other dispute that may occur. You know, we have a court system that deals with those sorts of processes. Just on, I think there was an aspect of that question around if one of the parties was overseas. Is that correct?
Pardon me?
Was there an aspect of that question if one of the parties to some sort of legal process was overseas?
Exactly.
Yeah, so that's where it gets difficult. So there's the data protection side of things, obviously. So, you know, most countries for healthcare, Australia included, and I think Indonesia growing to do so, requires that health data is stored within the country. And that's so that if there is a breach of privacy, then you're not trying to prosecute some case about it in a foreign country and its legal systems and so forth. It gets very complicated. So as much as possible, the requirement is the data is stored within the country. Okay. In terms of the service, if there's any issue about the service that's provided, then there'd be an agreement between the provider, the healthcare provider, the platform provider, and then the consumer, and that should outline, you know, what happens in the case of some sort of legal dispute. Again, it can get complicated if it's overseas, and also there's some clarity that needs to be defined about, you know, is this a medical service? And if that's the case, there's a whole range of legislation and so forth that comes into play. If it's an advisory or, you know, non-committal service, then, you know, there's less barriers, if you like, or less enforceability about some of those dimensions.
Okay, so you're gonna stick to the agreement, actually. And Jeff, one more question from Dr. Nico Azari Hidayat. Yes. Hi, Dr.
Nico.
It's about how's the proportion user of telemedicine government and private in Australia. I mean, like, how about the regulation? The proportion, and how about the regulation?
So, yeah, to tell the truth, I'm not quite sure about the proportion of the providers. So I mentioned Health Direct Australia. That's a government-funded organisation. I honestly don't know what its proportion. I'll have to take that on notice, Dr. Nico, and get back to you, I think. And what was the other aspects?
Other aspect is about the, I think like it's related to the regulation in Australia, actually. About the
I've talked a bit about some regulations already. Is there a particular type of regulation that you'd like me to talk, a different type?
I think it's like some kind like the regulation between the government and also the private in Australia, if I'm not mistaken. How when you're running the telemedicine system, and then how about the regulation between the medicine in government and also in private in Australia?
Yeah, I'm struggling to understand the question a little bit there. I'm sorry. Yeah, I'll have to try to understand, and I'll get back to you on that one.
Oh, okay, thank you. Okay, I will move to the Mr. Saguri. Actually, this is question from Azid. Azid from UGM, Universitas Gajah Mada University from Yogyakarta in Indonesia. Actually, question to Prof. Taguri. There is a significant decreased number of chronic patient visit to hospital in the early of pandemic. Is there any follow-up study for their current condition? Or is telehealth really can replace hospital visit for the chronic patients? So this is have two questions actually. Is there any follow-up study for their current condition? And the second one is telehealth really can replace hospital visit for the chronic patient?
Yes. So I don't know whether he means a study for chronic conditions or internationally. So if it's in Libya, no, there isn't such a study. But internationally, of course, there are many. For example, the one that I'm particularly interested in, and I like the idea, is about the intellectual performance of people chronic after a chronic illness. I like this because me personally, I had been infected, for example, and somehow I try to memorize the names. For example, I have difficulties. So of course, so there are proofs that there are chronic illnesses that not only losing taste or smell, but also things like intellectual performance, specifically memorizing. I think that was the most common of these. In Libya, we don't have any chronic study about chronic illnesses after COVID, long COVID. That the first part. The second question,
the second question is related to, is telehealth really can replace hospital visit for the chronic patient?
Yes, in our condition, because that's what we're thinking about in diabetes management. So we have a diabetic center that contains 100,000 population. And diabetes is one of the risk factors for COVID-19, for mortality in COVID-19. Most of diabetics are above 60 years, 70 years, so because at older ages, the proportion of diabetics are much more. So this is really a risk. And doing prescription or some of the follow-up of these patients, some of the ordinary follow-up, for example, your glycosylated hemoglobin is okay or it's not okay. These sort of things could be done easily, I think safely, which is important in quality and accreditation, safety of patients. These things could be done safely. I think it's not a all or none law. It's something that depends on what we are looking for in chronic illnesses. So it depends what chronic illness, what are we looking for in this chronic illness, and what is the skill of the treating doctors. There is another project that we are doing probably with UNDP. Maybe we could succeed it. I don't know. It's not yet launched. Is to what are the standards that should be followed up in following patients through digital health application, because I should accredit. It's type of accreditation. We should accredit a center that is capable of delivering health services online. So these are not yet answered questions, but definitely there are things that are good, some are not at all, and some are gray areas that needs much more discussion and study.
So this is depend on the patient condition actually. And then back to Jeff, I have one more question from the participant, and also from Mr. Taguri, I have one more question from the participant. The first for Mr. Jeff. Hi Jeff, this is from Nora Nindi Arista. She curious about how Australian government regulate the telemedicine services managed by private sector. So Nora asked you about how Australian government regulate the telemedicine services managed by private sector. I mean, like in terms of data security, ethics, and legal, etc.
Yes, so those frameworks already exist. Like I mentioned before, there's the privacy frameworks, there's the requirement to prove compliance with the digital health standards. So there's a quite a sophisticated regulation framework that controls the telehealth platform providers, and I'm not sure that there's a view that there's much missing in that area at the moment, and it's not inhibiting organisations or commercial providers in wanting to enter the market, for example. Just have to make sure they comply with the privacy and the standards, etc. Yeah, I think that they're probably the main things that I can think of just at the moment.
Thank you very much, Jeff. So we are moved to Mr. Taguri. This is one last question from the participant. This is coming from Nora, still from Nora. She wants to know about the understanding a lot of challenging with conflict and others. How the telemedicine service accepted by the people in Libya? I mean, like, do they willing to use it or any challenges on this? And how the government address this issue? Actually, you already mentioned it in the first present, but I think you can remind us again about how the telemedicine service accepted by the people in Libya, and do they willing to use or any challenges on this?
Yes, there's a good internet connection. I mean, most of the population, just for memorizing, there are 6 million population, but there are more than 5 million, I think, no, there are 5.5 million population, or almost 6, but there are 7 mobile line, and most of these, they use net connection. So that's one thing. The second thing, social media specifically are much used by the population, especially Facebook. And having this Facebook with the Spitar is also not only the application, but they have their social media platform. There are so many responses, but most, from I see my personal view, most of those who are responding and interacting are young people. So I think most of those who tend to use these online services are young first. The second thing, they target some special diseases, and that's why, because the system is responsive, it appears. So many talking about mental health. Mental health is something that is not really accepted to go to a psychiatric clinic in the country because of many social things. So that is shaped somehow. And I see that the mental health response, and it according to demands of clients, is there in Facebook, in the media, the page of Spitar. From that point, it's the young generation, it's certain specific diseases or issues that are mostly shaped by the population. But from the health authority, most of health or decision makers are older age, let us say. They are not really pro social media, they are not pro online. So they are not really using it. So I think the generation gap in Libya is really very wide, and that's why it shapes. Probably if we could make a strategy and prepare for the future, I strongly convinced that in the next 10 years, there would be a tremendous change in the way that digital means are applied in health in Libya.
So in Libya, social media platform also has an important role to develop the telemedicine ecosystem, Mr. Taguri. Okay, I think that's enough the question from the participant, but I still have one more question. This is the last question after we are going to close this event. So the last question is, Jeff and Mr. Taguri, it's related to public perception and response toward telemedicine provision in your country, in Australia and also in Libya. So based on related to research findings or probably from community survey, how is the satisfaction level after using the telemedicine in Australia and also in Libya? Can you tell us and sharing with us about this question? Maybe Mr. Taguri first before I'm going to waiting.
Yes, I think I presented something this time. Those who on spit out, they did it. They have two quantitative studies, and it showed that people, those who used it are satisfied. More than 75% are satisfied with the service. But it also from qualitative study where people in the response in social media is very positive, is very encouraging. I wouldn't take this lightly because people in the last years in social media are very not courageous, but let us say are very critical in their opinions when they do it publicly about an institution. So they would be very, not reluctant to accept anything. So they're really very critical, and having such a good response, I think there is a very good room from the public points of view to expand the use of digital health. But it's the role of decision makers to make it successful.
Okay, thank you, Mr. Taguri. And how about you, Jeff? Do you have another experience in Australia?
Yeah, just a couple of quick points, I guess. So I mentioned that the reported use of telehealth consults nearly doubled in the second year of the last 2 years. So I guess that's an indication that people are becoming more familiar with it and more accepting, and hopefully they're getting satisfaction from it as well. I am aware too that the promotion of telehealth as an option also has been quite widely done in Australia. So it's becoming more. People are becoming more aware of it, and so when the GP says or the receptionist says, how about we do this consult by telehealth? I think there's less of a barrier. There's more awareness that that's an okay thing to do, and obviously more people are trying it. So I don't have data about any satisfaction surveys that have been done. I'm certain that they have been done, but I could probably find those if anyone's interested.
Okay. Thank you very much, Jeff, and also Mr. Taguri. I think it's come to the end of the discussion, to the panelization. I'm very excited actually this afternoon. It's very, very productive Saturday for me. Thank you for sharing with us. If I'm not mistaken, I have several conclusions here. Listen, learn from Australia and also from Libya. From Mr. Taguri, I have concern about how to convince the decision maker, and then also social media platform also has an important role in Libya, and then in Libya has a positive user evaluation. So if I'm not mistaken, SPITAR is mean hospital, Mr. Taguri?
Yes, it means hospital.
Hospital, okay. So I think from Australia and also from Libya, we can learn about how we can manage and to do a lot of homework in Indonesia, such as infrastructure, and also from the human resources, and also from the regulation. Because in my opinion, if we have want to making good and also the effective regulation, it is based on the data. So we should have the good data and also valid data and also data that we can responsible to the community or to the people in Indonesia and also another country. So every country has their own challenges and also have their own opportunities. But one thing for sure, we have to collaborate one to another between government and also between the private sector and also between the hospital. We should have some good regulation also to manage the ecosystem of telemedicine. And this is very good and very insightful for me today. I learned a lot from you, Jeff, and from you, Mr. Taguri. So I want to say thank you, especially for two of you, and also special thank you for our resource person today, for Mr. Irwan Herianto, Mr. Setiaji, Mr. Ciprianus Batesoro, and for Daniel Oscar Baskoro, and also for Mr. Farouk Kureis, and then Mr. Surahyo, and also guys, for two of you, Mr. Jeff Parker and for Mr. Adel El Tagore from Libya and also from Australia. Okay, dear participant, thank you so much for your attention today, for your time, for your knowledge, and also for your experiences. We would like to thank to the participant also who joined the webinar today. Ladies and gentlemen, our discussion today are very insightful and very meaningful, as we know. And then I think the challenges will be there. We still fight against the pandemic COVID-19, but I do believe in every challenges, there will always be opportunities for us and potential opportunities. And also, opportunities and potential will be rising from the spirit of collaboration and synergies between us, from the government, also either from the community, and also from the people in Indonesia or from another country. We sincerely hope the output of today's discussion can immediately implement it. So finally, I'm Dini Octavianti as your master of ceremony and your moderator today. From the deepest of my heart, I do apologize for any mistake in presenting this webinar, but thank you very much for joining us today. Thank you very much, ladies and gentlemen, for your attention, and see you on the next event. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, everyone.